Welcome to this foundational lecture in HTL 308, where we begin an in-depth exploration of mature lymphoid neoplasms, a critical and complex group of hematologic malignancies that demand a sophisticated integration of pathology and histotechnology. As advanced students preparing for roles in clinical laboratories and diagnostic pathology, it is essential to appreciate how these diseases challenge and shape our laboratory workflows, from specimen receipt to final diagnostic reporting. Mature lymphoid neoplasms are clonal proliferations of differentiated lymphocytes, primarily B cells, T cells, or natural killer NK cells that have completed their development in lymphoid tissues. This category includes a broad spectrum of disorders such as chronic lymphocytic leukemia, follicular lymphoma, mantle cell lymphoma, Hodgkin lymphoma, and plasma cell neoplasms like multiple myeloma. Each entity exhibits distinct histological patterns, immunophenotypic profiles, and genetic abnormalities, which collectively guide diagnosis, prognosis, and treatment strategies. For histotechnologists, understanding these neoplasms extends beyond recognizing abnormal cells under the microscope. It requires mastery of specimen triage to ensure that tissue samples are optimally preserved and processed. For instance, lymph node biopsies and bone marrow specimens must be fixed appropriately, often in neutral buffered formalin for routine histology, or in specialized media for flow cytometry or molecular studies. Decalcification protocols for bone marrow biopsies must balance adequate mineral removal with preservation of antigenicity to maintain staining quality for immunohistochemistry, IHC. Poor fixation or over-decalcification can obscure cellular details or compromise antigen detection, leading to diagnostic pitfalls. Immunohistochemistry is indispensable in this field, enabling differentiation between B-cell and T-cell neoplasms, subclassification of lymphoma types, and identification of key markers such as CD20, CD3, CD30, and Ki67. Your role in performing and troubleshooting IHC stains directly impacts the pathologist's ability to interpret these markers accurately. Furthermore, flow cytometry complements histology by providing rapid immunophenotypic profiles of lymphoid populations in fresh specimens, while molecular and cytogenetic testing detect chromosomal translocations and gene mutations that refine diagnoses and inform targeted therapies. Throughout this lecture series, we will emphasize diagnostic reasoning that integrates morphological features with ancillary test results and clinical information. Recognizing common pitfalls, such as reactive lymphoid hyperplasia mimicking lymphoma or technical artifacts masking neoplastic cells, is vital to avoid misdiagnosis. By mastering these concepts and techniques, you will contribute significantly to the multidisciplinary team's efforts to deliver precise, timely diagnoses that guide effective patient management. As we proceed, keep in mind that your expertise in specimen handling, staining quality, and ancillary testing preparation is not merely technical, but foundational to the entire diagnostic workflow. This lecture will prepare you to meet the challenges posed by mature lymphoid neoplasms and highlight the critical role histotechnologists play in advancing hematopathology and patient care. Next, we will delve into the specific reasons why mature lymphoid neoplasms are particularly significant in the histotechnology laboratory setting. As we begin our exploration of mature lymphoid neoplasms, it is essential to understand why these diseases hold such significance within the scope of histotechnology. Mature lymphoid neoplasms encompass a diverse group of disorders arising from post-thymic lymphocytes, including various types of non-Hodgkin lymphomas, Hodgkin lymphoma, and plasma cell dyscrasias. Their diagnosis relies heavily on the integration of morphological assessment, immunophenotyping, and molecular studies, all of which depend on the quality and appropriateness of specimen handling and processing in the histology laboratory. From a histotechnologist's perspective, recognizing the clinical suspicion of a lymphoid neoplasm early in the workflow profoundly influences how specimens are triaged and processed. For example, peripheral blood samples flagged for lymphocytosis require careful preparation of right-gem-sustained smears to highlight abnormal lymphoid populations. Identifying subtle cytologic features such as nuclear irregularities or cytoplasmic granules can guide further diagnostic steps. Similarly, bone marrow aspirates and biopsies present unique challenges. In disorders like hairy cell leukemia, aspirates may be hypocellular or yield dry taps, necessitating reliance on core biopsies. Proper fixation and decalcification protocols are critical here to preserve marrow architecture and antigenicity for downstream immunohistochemistry and molecular testing. When dealing with lymph node or extranodal tissue biopsies, the preservation of tissue architecture is paramount. Many lymphomas require evaluation of nodal architecture, follicular patterns, and the relationship between neoplastic cells and the microenvironment. Overfixation or harsh decalcification can compromise antigen preservation, negatively impacting immunohistochemical staining quality. As histotechnologists, your role in selecting appropriate fixatives, controlling fixation times, and choosing decalcification methods that balance tissue softening with antigen preservation directly affects the diagnostic yield. This is especially important when panels include markers such as CD3, CD20, CD5, cyclin D1, and others that help delineate lineage and subtype, information critical for accurate classification and treatment planning. Moreover, your expertise extends to preparing specimens for ancillary studies like flow cytometry and molecular cytogenetics. Flow cytometry requires fresh, well-preserved cells, so timely specimen transport and processing are vital. Molecular tests demand nucleic acid integrity, which can be compromised by improper fixation or prolonged storage. Understanding these requirements allows you to anticipate testing needs and communicate effectively with pathologists and clinicians, ensuring specimens are handled to maximize diagnostic accuracy. In addition to technical skills, recognizing common pitfalls is crucial. For instance, smudge cells in chronic lymphocytic leukemia can be mistaken for artifacts if not properly identified, potentially leading to misinterpretation. Preparing albumin smears to stabilize fragile lymphocytes exemplifies how histotechnologists can enhance specimen quality and diagnostic confidence. Ultimately, mature lymphoid neoplasms exemplify the intersection of pathology, histology, and laboratory science where your role is indispensable. Your meticulous attention to specimen triage, fixation, staining, and ancillary testing preparation directly impacts the pathologist's ability to render a precise diagnosis, which in turn guides patient management. As we proceed, the assigned readings and learning objectives will deepen your understanding of these diseases and reinforce the critical contributions you make in the clinical laboratory setting. As we begin this module, it is essential to understand the roadmap that will guide our exploration of mature lymphoid neoplasms, a complex and diagnostically challenging group of hematologic malignancies. This slide outlines the 3 foundational readings that structure our learning journey, each representing a critical pillar in the histotechnologist's and hematopathologist's toolkit: morphology, immunophenotyping, and molecular diagnostics. Together, these domains form the backbone of accurate diagnosis, effective specimen processing, and ultimately, patient care. The first reading immerses you in the morphological landscape of lymphoid neoplasms. Here, we focus on the microscopic evaluation of peripheral blood smears, bone marrow aspirates and biopsies, and lymph node or extranodal tissue sections. Morphology remains the cornerstone of histopathology, and your ability to discern subtle cytologic features, such as nuclear chromatin texture, nucleolar prominence, cytoplasmic granularity, and the architectural arrangement of lymphoid cells within tissue, is paramount. For instance, recognizing the classic popcorn cells of nodular lymphocyte-predominant Hodgkin lymphoma, or the monomorphic small lymphocytes with irregular nuclei in chronic lymphocytic leukemia, can direct subsequent testing and diagnosis. This reading also emphasizes the importance of proper fixation and decalcification protocols, as these pre-analytical steps profoundly affect cellular detail preservation and staining quality, which are crucial for confident morphological interpretation. Building on morphology, the second reading delves into immunophenotyping techniques, particularly flow cytometry and immunohistochemistry. These methods allow us to characterize the lineage and differentiation stage of lymphoid cells by detecting specific surface and intracellular markers. Understanding the expression patterns of markers such as CD19, CD20, CD5, CD10, and cyclin D1 is vital, as they help differentiate entities that may appear morphologically similar but have distinct clinical implications. For example, distinguishing mantle cell lymphoma from chronic lymphocytic leukemia hinges on identifying cyclin D1 overexpression and the presence of CD5. From a histotechnology perspective, mastering staining protocols, antigen retrieval methods, and quality control measures ensures reliable immunohistochemical results. Additionally, flow cytometry requires meticulous specimen triage and processing to preserve cell viability and antigenicity, underscoring the integrated nature of laboratory workflow. The third reading introduces molecular and cytogenetic diagnostics, which have revolutionized hematopathology by uncovering genetic abnormalities that define and stratify lymphoid neoplasms. Techniques such as fluorescence in situ hybridization, FISH, and polymerase chain reaction, PCR-based assays, detect hallmark translocations like T11, 14, in mantle cell lymphoma, or mutations like BRAF V600E in hairy cell leukemia. These molecular insights not only confirm diagnoses, but also provide prognostic information and guide targeted therapies. As histotechnologists, understanding the specimen requirements, fixation conditions, and nucleic acid preservation strategies is critical to support these advanced tests. By integrating these three domains, morphology, immunophenotyping, and molecular diagnostics, you will develop a comprehensive diagnostic reasoning framework. This multi-parameter approach is essential to navigate the diagnostic pitfalls that arise from overlapping features, sampling artifacts, or suboptimal specimen handling. Throughout this module, we will emphasize practical skills in specimen triage, fixation, decalcification, staining quality assessment, and interpretation of immunohistochemical and flow cytometric data. These competencies are indispensable for delivering accurate, timely diagnoses in mature lymphoid neoplasms. With this roadmap in mind, we are now prepared to delve deeper into the biological basis of clonal proliferation in lymphoid neoplasms, setting the stage for understanding their diverse morphological and molecular characteristics. As we transition into the critical concept of clonal proliferation, it is essential to appreciate how the normal processes that generate immune diversity can paradoxically set the stage for neoplastic transformation. Lymphoid cells, comprising B cells, T cells, and natural killer NK cells, undergo a highly orchestrated series of gene rearrangements during their development. This somatic recombination of variable V, diversity D, and joining J gene segments is fundamental to creating the vast repertoire of antigen receptors necessary for adaptive immunity. From a histotechnologist's perspective, this molecular choreography is not just an abstract concept. It directly impacts how we approach specimen triage, fixation, staining, and ancillary testing. During lymphocyte maturation, the DNA breaks and rejoining events inherent to VDJ recombination introduce vulnerability to chromosomal translocations and oncogenic mutations. These genetic alterations can disrupt normal regulatory pathways, leading to unchecked proliferation of a single clone, a hallmark of neoplasia. For example, the T14, 18, Q32, Q21 translocation in follicular lymphoma results in the juxtaposition of the BCL2 gene next to the immunoglobulin heavy chain locus. This causes overexpression of the anti-apoptotic BCL2 protein, allowing the malignant clone to evade programmed cell death. Similarly, mantle cell lymphoma is driven by the T11, 14, Q13, Q32 translocation, which dysregulates cyclin D1 and promotes abnormal cell cycle progression. Understanding these molecular events is crucial because the phenotype of the resulting neoplasm reflects both the lineage, whether B cell, T cell, or NK cell, and the stage of maturation at which transformation occurred. This biological diversity explains why mature lymphoid neoplasms exhibit such heterogeneity in morphology and clinical behavior. Consequently, morphology alone is insufficient for definitive diagnosis. This is where the histotechnologist's role becomes pivotal. Proper fixation and decalcification protocols must preserve antigenicity to enable reliable immunohistochemical staining, which is indispensable for lineage assignment and clonality assessment. For instance, detecting cyclin D1 overexpression or BCL2 protein by immunohistochemistry can confirm the diagnosis suggested by morphology and clinical context. Moreover, flow cytometry and molecular techniques such as fluorescence in situ hybridization, FISH, or polymerase chain reaction, PCR, for gene rearrangements, complement histologic evaluation by identifying clonal populations and specific genetic abnormalities. Specimen handling protocols must ensure that fresh tissue is appropriately allocated for these ancillary studies, as formalin fixation can compromise nucleic acid integrity. Awareness of these requirements helps avoid common pitfalls, such as insufficient tissue sampling or inappropriate fixation, which can delay or obscure diagnosis. In summary, the journey from immune diversity to neoplasia is a double-edged sword. While gene rearrangement enables adaptive immunity, it also creates vulnerabilities that can lead to clonal expansion and lymphoma development. For histotechnologists, integrating knowledge of these molecular underpinnings with meticulous specimen processing and staining techniques is essential to support accurate diagnosis and patient management. With this foundation, we are now prepared to explore the practical laboratory distinctions between leukemia and lymphoma, a critical step in guiding specimen handling and diagnostic interpretation. As we transition into the practical laboratory distinction between leukemia and lymphoma, it is essential to appreciate how this differentiation shapes every step of our histotechnology workflow and diagnostic reasoning. Mature lymphoid neoplasms encompass a broad spectrum of diseases that, while biologically related, manifest in distinct clinical and pathological contexts. The terms leukemia and lymphoma are not merely semantic. They reflect fundamental differences in tissue involvement, specimen types, and laboratory approaches that directly influence how we process, stain, and interpret diagnostic material. Leukemias primarily involve the peripheral blood and bone marrow. In these cases, abnormal lymphoid cells circulate in the bloodstream and infiltrate the marrow, often leading to characteristic hematologic abnormalities such as lymphocytosis or cytopenias. Chronic lymphocytic leukemia, CLL, and prolymphocytic leukemia, PLL, are classic examples where the diagnostic specimen is typically a peripheral blood smear or bone marrow aspirate. For the histotechnologist, this means that specimen triage must prioritize optimal smear preparation and fixation to preserve cellular detail. Right GIM sustaining quality is paramount to distinguish subtle cytologic features, such as the presence of smudge cells in CLL, which can be a diagnostic clue, but also a potential pitfall if overinterpreted as artifact. Additionally, bone marrow biopsies require careful decalcification protocols that preserve antigenicity for subsequent immunohistochemical and molecular testing, which are critical for confirming lineage and clonality. In contrast, lymphomas predominantly present as tissue masses involving lymph nodes, spleen, or extranodal sites like the gastrointestinal tract or skin. Follicular lymphoma and diffuse large B-cell lymphoma, DLBCL, exemplify this group. Here, the histotechnologist's role centers on preserving tissue architecture through proper fixation and embedding. This architectural context is vital for pathologists to assess growth patterns, nodal architecture, and the relationship between neoplastic cells and the microenvironment. Immunohistochemistry panels are routinely employed to characterize cell lineage, differentiation status, and proliferation indices. Furthermore, molecular and cytogenetic studies often require well-preserved nucleic acids, underscoring the importance of standardized fixation and processing protocols. It is important to recognize that the distinction between leukemia and lymphoma is not always absolute. Some lymphomas may exhibit a leukemic phase with circulating malignant cells, while certain leukemias can form nodal or extranodal masses. This overlap necessitates a multi-parameter diagnostic approach, integrating morphology, immunophenotyping, flow cytometry, and molecular genetics. From a histotechnologist's perspective, understanding the clinical context and specimen source guides appropriate triage decisions, ensuring that each sample receives the correct processing and ancillary testing to support an accurate diagnosis. In summary, distinguishing leukemia from lymphoma in the laboratory is a practical exercise that requires a nuanced understanding of pathology, specimen handling, and diagnostic techniques. Mastery of these concepts aligns with our HTL 308 learning goals by reinforcing the critical link between histotechnology practices and clinical outcomes. As we proceed, we will explore the World Health Organization's multi-parameter classification system, which synthesizes morphology, immunophenotype, genetics, and clinical data to refine the diagnosis of mature lymphoid neoplasms. As we delve into the World Health Organization's approach to diagnosing mature lymphoid neoplasms, it is crucial to appreciate that morphology alone, while foundational, is not sufficient for a definitive diagnosis. In histotechnology and pathology, morphology, the microscopic examination of tissue architecture, cellular size, nuclear features, and chromatin patterns, serves as the initial and indispensable step. It provides the first clues about whether a lymphoid proliferation is reactive or neoplastic. and if neoplastic, whether it involves B cells, T cells, or plasma cells. However, many lymphoid neoplasms share overlapping morphologic characteristics, making it impossible to rely solely on histology for precise classification. This is where the WHO classification system's multi-parameter diagnostic approach becomes essential. Beyond morphology, immunophenotyping through immunohistochemistry, IHC, and flow cytometry is critical. These techniques allow us to identify lineage-specific markers and differentiate between closely related entities. For example, CD3 positivity confirms T-cell lineage, while CD20 and PAX5 are hallmark B-cell markers. Additional markers such as CD5, CD10, CD23, and cyclin D1 help refine the diagnosis further. For instance, the presence of cyclin D1 is a key feature distinguishing mantle cell lymphoma from chronic lymphocytic leukemia, which may otherwise appear similar morphologically. Ki-67 staining provides valuable information about the proliferation index, which can influence prognosis and therapeutic decisions. In parallel, cytogenetic and molecular studies detect characteristic chromosomal translocations and gene mutations that carry both diagnostic and prognostic weight. The T11, 14, Q13, Q32 translocation involving cyclin D1 is pathognomonic for mantle cell lymphoma, while the BRAF 5600E mutation is a defining feature of hairy cell leukemia. These molecular signatures not only confirm the diagnosis, but also guide targeted therapies and clinical management. From a histotechnologist's perspective, understanding this integrated diagnostic workflow underscores the importance of specimen triage and processing. Proper fixation, decalcification when necessary, and careful preparation of tissue sections are vital to preserve antigenicity for IHC and nucleic acid integrity for molecular testing. Inadequate fixation or over-decalcification can compromise staining quality and lead to false negative or inconclusive results. Furthermore, allocating appropriate tissue for flow cytometry and molecular studies during specimen triage ensures that pathologists have sufficient material to perform these ancillary tests without exhausting the sample. Ultimately, the WHO classification emphasizes that morphology initiates the diagnostic journey, but must be complemented by immunophenotypic, molecular, and clinical data to achieve an accurate and clinically meaningful diagnosis. This integrated approach not only improves diagnostic precision, but also informs prognosis and guides personalized treatment strategies. As we continue, we will explore how clinical presentation and laboratory findings influence specimen processing decisions and the overall diagnostic workflow in lymphoid neoplasms. As we transition into the critical topic of clinical clues that drive specimen workup, it is essential to appreciate how the initial clinical presentation profoundly influences every step of the histotechnology workflow in the diagnosis of mature lymphoid neoplasms. In HTL 308, our goal is to integrate pathology, histology, and laboratory science in a way that supports precise diagnostic reasoning and optimal patient care. Understanding the clinical context is not merely academic. It directly impacts specimen triage, fixation protocols, staining strategies, and the selection of ancillary studies such as immunohistochemistry, flow cytometry, and molecular testing. One of the most common and telling clinical signs in suspected lymphoid malignancies is lymphadenopathy. When a patient presents with painless enlargement of lymph nodes, especially in cervical or supraclavicular regions, this raises immediate suspicion for lymphoma. From a histotechnologist's perspective, recognizing this clue means prioritizing lymph node biopsies for prompt fixation and processing to preserve cellular morphology and antigenicity. Proper fixation is crucial here, as inadequate fixation can compromise immunohistochemical staining, which is often indispensable for subclassifying lymphomas. Another pivotal clinical clue is the presence of B symptoms: unexplained fever, drenching night sweats, and unintentional weight loss. These systemic symptoms suggest a higher tumor burden and more aggressive disease. They also alert the laboratory team to the urgency of specimen processing and the potential need for comprehensive ancillary testing. For example, immunophenotyping by flow cytometry may be expedited to rapidly characterize cell populations, while molecular studies might be prioritized to detect gene rearrangements or chromosomal translocations that influence prognosis and therapy. Cytopenias, manifesting as anemia, neutropenia, or thrombocytopenia, often indicate bone marrow involvement by neoplastic lymphoid cells or immune-mediated destruction. This clinical finding typically triggers a bone marrow biopsy, which poses unique histotechnological challenges. Bone marrow specimens require decalcification, a process that must be carefully controlled to avoid damaging nucleic acids and epitopes critical for downstream molecular and immunohistochemical assays. The histotechnologist must balance adequate decalcification with preservation of diagnostic detail, ensuring that marrow architecture and cellular detail remain interpretable. Organomegaly, such as splenomegaly or hepatomegaly, points to extranodal disease spread and influences biopsy site selection. When lymphoid neoplasms infiltrate organs beyond lymph nodes and marrow, specialized specimen handling is required. For instance, skin punch biopsies for cutaneous involvement demand meticulous orientation and embedding to evaluate epidermal and dermal layers. Similarly, cerebrospinal fluid or serous effusions require cytologic evaluation combined with immunophenotyping and molecular testing to detect malignant cells that may be scant or morphologically ambiguous. In all these scenarios, the histotechnologist's awareness of clinical clues ensures that specimen processing is tailored to the diagnostic question. This clinical pathologic correlation is fundamental to avoiding common pitfalls such as inadequate fixation, suboptimal staining, or incomplete ancillary testing, which can delay or obscure diagnosis. By aligning laboratory workflows with clinical presentation, we enhance diagnostic accuracy and contribute to timely, effective patient management. As we move forward, we will explore how these clinical clues inform laboratory triage decisions and how the type of specimen collected determines the suite of diagnostic modalities employed. This understanding will further refine your ability to integrate histotechnological expertise with clinical and pathological data in the diagnosis of lymphoid neoplasms. As we transition into the critical topic of laboratory triage in the evaluation of mature lymphoid neoplasms, it is essential to appreciate how the type of specimen received in the laboratory fundamentally shapes the diagnostic approach and workflow. In the context of hematopathology and histotechnology, the initial triage decision determines which diagnostic modalities will be employed, ranging from routine hematology tests to advanced immunophenotypic and molecular analyses, and how specimens must be processed to preserve diagnostic integrity. Starting with the complete blood count, or CBC, this automated screening tool provides an initial quantitative snapshot of the patient's hematologic status. While the CBC can reveal lymphocytosis or cytopenias suggestive of lymphoid neoplasia, it is inherently limited by its reliance on automated cell counters that cannot reliably distinguish subtle morphologic abnormalities or rare malignant cells. Therefore, peripheral blood smears remain indispensable. The smear allows for direct microscopic evaluation of cellular morphology, including nuclear chromatin patterns, cytoplasmic features, and the presence of abnormal cells such as prolymphocytes or plasma cells. High-quality right Giemsa staining is critical here. Poor staining can obscure diagnostic details or create artifacts that mimic pathology. For example, smudge cells, fragile lymphocytes disrupted during smear preparation, are characteristic of chronic lymphocytic leukemia but can be overrepresented if smearing technique is suboptimal. To mitigate this, albumin smears may be employed to stabilize cells and reduce artifact formation, underscoring the histotechnologist's role in specimen preparation. Moving to bone marrow evaluation, aspirates provide a cytologic perspective, allowing detailed assessment of individual cell morphology and differential counts. However, aspirates can be compromised by dry taps, particularly in fibrotic marrow environments seen in entities like hairy cell leukemia or myelofibrosis. In such cases, the bone marrow core biopsy becomes indispensable. The biopsy preserves marrow architecture and cellularity, enabling assessment of fibrosis through special stains such as reticulin or trichrome. Immunohistochemistry on biopsy sections further aids in lineage determination and clonality assessment, which are pivotal for accurate lymphoma subclassification. Importantly, fixation protocols must balance adequate tissue preservation with antigen retention to ensure reliable IHC staining and downstream molecular testing. Tissue biopsies, especially excisional lymph node biopsies, provide the most comprehensive information by preserving lymph node architecture, which is crucial for differentiating among various lymphoma subtypes. Proper fixation, typically in neutral buffered formalin, is essential to maintain morphology and antigenicity. When bone is present in the specimen, decalcification must be carefully managed. Harsh acid decalcifiers can degrade nucleic acids, compromising molecular and cytogenetic studies that are increasingly integral to lymphoma diagnosis and prognostication. Whenever possible, fresh tissue should be submitted for flow cytometry, which requires viable cells for immunophenotyping and clonality assessment. This highlights the importance of coordinated specimen triage and communication between clinicians, pathologists, and histotechnologists. Throughout this process, the histotechnologist's expertise in specimen handling, fixation, decalcification, sectioning, and staining quality control is vital. Each step influences the accuracy of morphologic evaluation, immunohistochemical staining, flow cytometric analysis, and molecular diagnostics. Missteps in triage or processing can lead to diagnostic pitfalls, such as false negative immunostains or inadequate material for genetic testing, ultimately impacting patient management. This overview of laboratory triage sets the foundation for our deeper exploration of mature lymphoid neoplasms. Understanding how specimen type guides diagnostic workflow and testing modalities is essential for appreciating the complexities of lymphoma diagnosis and the pivotal role histotechnology plays in ensuring diagnostic precision. Next, we will examine the quality control measures and histotechnology techniques that preserve tissue integrity and optimize diagnostic yield in lymphoid neoplasm evaluation. As we delve into the critical quality gates of histotechnology, fixation, decalcification, and fresh tissue handling, we are addressing foundational steps that profoundly impact the entire diagnostic cascade for lymphoid tissues and bone marrow specimens. These pre-analytic processes are not merely routine laboratory tasks, they are pivotal determinants of specimen integrity, influencing morphology preservation, immunohistochemical staining fidelity, molecular assay reliability, and ultimately, diagnostic accuracy in hematopathology. Fixation is the initial and arguably most crucial step in tissue processing. When lymph node or bone marrow biopsies arrive in the histology lab, the prompt and proper application of fixative, typically neutral buffered formalin, stabilizes cellular architecture by cross-linking proteins. This chemical stabilization preserves the fine histologic details that pathologists rely on to distinguish reactive from neoplastic lymphoid proliferations, to identify Reed-Sternberg cells in Hodgkin lymphoma, or to evaluate plasma cell morphology in disorders such as multiple myeloma. However, fixation is a delicate balance. If tissue blocks are too thick or fixation time is insufficient, autolysis ensues, leading to loss of nuclear detail and cytoplasmic clarity, which can obscure subtle diagnostic features. Conversely, overfixation can mask antigenic epitopes, diminishing the sensitivity of immunohistochemical stains critical for phenotyping lymphoid populations. For example, CD20 or CD3 staining intensity may be reduced, complicating the interpretation of B- versus T-cell lineage. Histotechnologists must therefore control tissue thickness, ensure adequate fixative volume, and adhere to standardized fixation times to optimize downstream testing. Decalcification presents a unique challenge in bone marrow biopsies that include bone trabeculae. The choice of decalcifying agent directly affects the preservation of nucleic acids and protein epitopes. Strong acid decalcifiers such as hydrochloric acid or formic acid expedite bone softening but at the cost of degrading DNA and protein targets, which compromises molecular diagnostics and immunohistochemistry. This degradation can lead to false negative results in assays like fluorescence in situ hybridization, FISH, or PCR-based clonality studies, which are essential in diagnosing mature lymphoid neoplasms and plasma cell disorders. In contrast, EDTA-based decalcification is gentler and better preserves antigenicity and nucleic acid integrity, albeit requiring longer processing times. Selecting the appropriate decalcification protocol is a critical decision point that histotechnologists must make in collaboration with pathologists and molecular laboratories to maintain the diagnostic utility of bone marrow specimens. Fresh tissue handling is equally vital, especially for ancillary studies such as flow cytometry and molecular testing. Flow cytometry requires viable cells to accurately assess immunophenotypic profiles, which are indispensable in classifying lymphomas and detecting minimal residual disease. Molecular assays depend on intact DNA or RNA, which fixation irreversibly alters. Therefore, Histotechnologists must coordinate closely with clinical teams to ensure that fresh tissue is promptly collected, transported under appropriate conditions, and triaged correctly. Failure to secure fresh tissue can preclude these sensitive analyses, limiting diagnostic precision and potentially delaying patient care. In summary, the quality gates of fixation, decalcification, and fresh tissue management are integral to the histotechnology workflow and directly influence the accuracy of multi-parameter diagnoses in mature lymphoid neoplasms, Hodgkin lymphoma, and plasma cell disorders. Mastery of these processes enables histotechnologists to safeguard specimen integrity, optimize staining quality, and support the complex diagnostic reasoning required in hematopathology. As we proceed, we will explore how peripheral blood film review complements automated screening methods by detecting subtle lymphoid abnormalities, further enhancing our diagnostic capabilities. As we transition into the critical topic of peripheral blood film review and what automated flags may miss, it is essential to appreciate the integral role that manual microscopic examination continues to play in hematopathology and histotechnology workflows. While automated hematology analyzers have revolutionized laboratory efficiency by rapidly generating complete blood counts and differential leukocyte counts, their capabilities have inherent limitations, especially when it comes to detecting subtle morphological abnormalities. This gap underscores the necessity for skilled manual review of peripheral blood smears, a process that remains indispensable for accurate diagnosis and specimen triage. Automated analyzers excel at quantifying cell populations and flagging gross abnormalities, such as marked leukocytosis or thrombocytopenia, but they lack the nuanced sensitivity to identify certain diagnostic clues embedded within cell morphology. For example, in mature lymphoid neoplasms like chronic lymphocytic leukemia, CLL, the presence of smudge cells, fragile lymphocytes that rupture during smear preparation, is a hallmark feature that automated systems cannot reliably detect or interpret. These smudge cells, along with small mature lymphocytes exhibiting characteristic nuclear chromatin patterns, provide critical morphological evidence that guides the pathologist toward a CLL diagnosis. Without manual review, these subtle yet diagnostically significant features might be overlooked, potentially delaying appropriate downstream testing such as immunophenotyping by flow cytometry or molecular and cytogenetic analyses. Moreover, manual smear examination allows for the identification of atypical lymphocytes with irregular nuclear contours, cytoplasmic granules, or other aberrant features that may suggest alternative lymphoid neoplasms or reactive processes. Recognizing these morphological variants is vital because they influence the selection of ancillary studies, including immunohistochemistry panels and molecular assays, which are essential for precise classification and prognostication. This diagnostic reasoning process hinges on the histotechnologist's ability to prepare high-quality smears and maintain consistent right-GIMSA staining protocols. Suboptimal fixation or staining can obscure delicate cellular details, leading to misinterpretation or misdiagnoses. From a workflow perspective, the histotechnologist's expertise in smear preparation and staining quality assurance directly impacts the pathologist's ability to perform accurate morphological assessment. This interplay exemplifies how histotechnology supports the broader clinical laboratory mission, bridging automated data with expert interpretation to inform patient management. As we delve deeper into the classification of lymphoid neoplasms, understanding the limitations of automation and the enduring value of manual peripheral blood film review will enhance your diagnostic acumen and appreciation for integrated laboratory diagnostics. In the next section, we will explore the core immunophenotypic markers that are pivotal for the classification of lymphoid neoplasms, building on the morphological insights gained from peripheral blood and tissue specimens. This integrated approach underscores the multidisciplinary nature of hematopathology and the critical role of histotechnologists in facilitating accurate, timely diagnoses. As we transition into the core marker logic for lymphoid workups, it is essential to appreciate how immunophenotyping serves as the cornerstone for diagnosing mature lymphoid neoplasms. In histotechnology and pathology, the integration of morphology with immunophenotypic data is critical for accurate classification, prognostication, and ultimately guiding patient management. This slide introduces the fundamental categories of immunohistochemical and flow cytometric markers that form the backbone of lymphoid neoplasm evaluation, emphasizing their practical application in the laboratory workflow. The first and most crucial step in any lymphoid workup is establishing lineage. Lineage markers, such as CD19 and CD20 for B cells, CD3 for T cells, and CD56 for natural killer cells, provide the initial framework by which we categorize the neoplastic population. This distinction is not merely academic. It directs subsequent marker selection and narrows the differential diagnosis. For example, a lymphoid infiltrate expressing CD20 and lacking T-cell markers immediately shifts the focus toward B-cell lymphomas, while CD3 positivity steers toward T-cell neoplasms. From a histotechnologist's perspective, ensuring optimal antigen preservation during fixation and processing is paramount to reliably detecting these lineage markers. Overfixation or inappropriate decalcification can mask epitopes, leading to false negatives and diagnostic confusion. Once lineage is established, maturation markers come into play to determine the developmental stage of the lymphoid cells. Markers like CD10 and CD34 help differentiate immature blasts, as seen in acute lymphoblastic leukemia, from mature lymphoid neoplasms. This distinction is vital because immature and mature lymphoid malignancies have vastly different clinical behaviors and treatment protocols. For example, CD10 positivity in a B-cell population may indicate a germinal center origin, which is relevant in follicular lymphoma diagnosis. Histotechnologists must be vigilant in optimizing staining protocols for these markers, as their expression can be subtle and variable depending on fixation and antigen retrieval methods. Aberrant antigen expression patterns provide another layer of diagnostic specificity. The presence of markers in unexpected lineages or the loss of pan-lineage markers often signals neoplastic transformation. For instance, CD5 expression on B cells is aberrant and characteristic of entities such as chronic lymphocytic leukemia or mantle cell lymphoma. Similarly, loss of pan-T cell markers like CD7 may indicate a T cell lymphoma. Recognizing these aberrancies requires a comprehensive panel approach rather than reliance on single markers, underscoring the importance of carefully designed immunohistochemistry panels and flow cytometry panels tailored to the clinical question. Proliferation markers, particularly Ki67, offer prognostic insight by quantifying the growth fraction of the neoplasm. A high Ki67 index correlates with aggressive clinical behavior and can influence therapeutic decisions. From a technical standpoint, Ki67 staining demands precise timing and standardized protocols to ensure reproducibility, as variability can impact interpretation and clinical correlation. Finally, clonality markers confirm the neoplastic nature of the lymphoid proliferation, demonstrating light chain restriction in B cells or T cell receptor gene rearrangements in T cells distinguishes clonal expansions from reactive processes. Molecular and cytogenetic testing complement immunophenotyping by providing definitive evidence of clonality, which is especially valuable in diagnostically challenging cases. For histotechnologists, understanding these core marker categories is not only about recognizing individual antigens, but also about appreciating the interplay between morphology, immunophenotyping, and molecular data. This integrated approach enhances diagnostic accuracy, reduces pitfalls such as misclassification or false negatives, and ultimately supports pathologists in delivering precise diagnoses. As we proceed, we will delve deeper into how immunophenotyping is fundamentally an exercise in pattern recognition, where the constellation of marker expression, rather than any single antigen, guides the diagnostic reasoning process in lymphoid neoplasms. As we transition into the critical concept that immunophenotyping is fundamentally an exercise in pattern recognition, it is essential to appreciate how this principle underpins accurate diagnosis in lymphoid neoplasms. In the realm of histotechnology and pathology, immunophenotyping is not simply about detecting the presence or absence of a single antigen. Rather, it involves interpreting complex patterns of marker expression across a panel of antibodies. This nuanced approach is vital for distinguishing among various mature lymphoid neoplasms, Hodgkin lymphoma, plasma cell disorders, and other hematolymphoid malignancies, all of which can present overlapping morphologies and clinical features. From a histotechnologist's perspective, the workflow begins with meticulous specimen triage, ensuring that tissue samples are appropriately fixed and, when necessary, decalcified without compromising antigenicity. Proper fixation preserves cellular detail and epitope integrity, which is crucial for both immunohistochemistry, IHC, and flow cytometry assays. Inadequate fixation or over-decalcification can lead to weak or false negative staining, obscuring the immunophenotypic patterns that pathologists rely on for diagnosis. Therefore, the quality control measures we implement during tissue processing directly impact the reliability of immunophenotypic data. When we examine immunophenotyping results, whether from flow cytometry dot plots or IHC panels, the interpretive challenge lies in recognizing characteristic combinations of markers rather than isolated findings. For example, in chronic lymphocytic leukemia/small lymphocytic lymphoma, CLL/SLL, the co-expression of CD5 and CD23 on B cells forms a distinctive pattern that supports diagnosis. In contrast, mantle cell lymphoma typically shows CD5 positivity but lacks CD23 expression and exhibits cyclin D1 positivity, a pattern that helps differentiate it from CLL/SLL despite some overlapping features. These patterns are not arbitrary. They reflect underlying biology and maturation stages of the neoplastic cells. Aberrant antigen expression is another critical clue. Loss of pan-T cell markers or unexpected co-expression of antigens can signal malignancy and assist in subclassifying lymphomas. For instance, a T-cell lymphoma might lose CD7 expression or aberrantly express CD56, findings that are subtle but diagnostically significant. Recognizing these aberrancies requires a comprehensive panel and careful correlation with morphology and clinical data. Integration of immunophenotypic information with histologic features and patient history is indispensable. Immunophenotyping alone cannot stand in isolation. It must be interpreted in the context of lymph node architecture, bone marrow involvement, and clinical presentation. This holistic approach reduces the risk of misclassification and ensures that diagnoses are both precise and clinically meaningful. For histotechnologists, this means maintaining rigorous standards in staining protocols, antibody validation, and flow cytometry assay performance. Consistency and reproducibility in these technical steps provide the foundation for accurate pattern recognition by pathologists. Ultimately, immunophenotyping exemplifies how multiple data points converge to form a diagnostic pattern, underscoring the importance of expertise and attention to detail in the laboratory. As we move forward, we will explore how cytogenetic and molecular alterations complement immunophenotyping by serving as diagnostic and prognostic anchors in mature lymphoid neoplasms. Understanding these integrated diagnostic modalities will further enhance our ability to classify and manage hematolymphoid malignancies effectively. As we transition into the critical topic of cytogenetics and molecular anchors in mature lymphoid neoplasms, it is essential to appreciate how these genetic alterations have revolutionized our diagnostic and prognostic capabilities in hematopathology. For histotechnology professionals, understanding these molecular landmarks is not merely academic. It directly impacts specimen triage, fixation protocols, and downstream testing quality, all of which are integral to the workflow in a modern clinical laboratory. Cytogenetic and molecular abnormalities serve as definitive anchors that help distinguish lymphoma subtypes with overlapping morphologic and immunophenotypic features. For example, rearrangements involving the MYC, BCL2, and BCL6 genes define a subset of aggressive diffuse large B-cell lymphomas known as double or triple-hit lymphomas. These genetic events confer a poor prognosis and necessitate more intensive therapeutic regimens. Recognizing these rearrangements through fluorescence in situ hybridization, FISH, or molecular assays is crucial because morphology alone cannot reliably identify these high-risk cases. Similarly, the hallmark T11, 14, Q13, Q32 translocation, which juxtaposes the CCND1 gene with the immunoglobulin heavy chain, IgH locus, is pathognomonic for mantle cell lymphoma. This translocation leads to cyclin D1 overexpression, a key diagnostic marker routinely detected by immunohistochemistry. For histotechnologists, ensuring optimal fixation and avoiding decalcification artifacts in bone marrow biopsies or lymph node specimens is vital to preserve antigenicity and nucleic acid integrity for these tests. Mutations in TP53 represent another critical molecular anchor, frequently associated with therapy resistance and adverse outcomes across various lymphoma subtypes. Detecting TP53 aberrations informs prognostication and may influence therapeutic decisions. Likewise, the BR5600E mutation is a defining feature of hairy cell leukemia, guiding both diagnosis and the use of targeted inhibitors, underscoring the importance of molecular testing and personalized medicine. In lymphoplasmacytic lymphoma, including Waldenstrom macroglobulinemia, MYD88 mutations and IGH rearrangements provide molecular confirmation that complements clinical and histologic findings. These molecular signatures link directly to the disease's pathophysiology and clinical behavior, illustrating how integrated diagnostics enhance accuracy. From a histotechnology perspective, these molecular anchors emphasize the necessity of meticulous tissue handling, fresh tissue submission, prompt fixation in neutral buffered formalin, and avoidance of harsh decalcification agents preserve DNA and RNA quality for molecular assays. Failure to adhere to these protocols can lead to suboptimal staining, false negative results, and diagnostic delays. Ultimately, the integration of cytogenetic and molecular data with morphology and immunophenotyping completes the multi-parameter diagnostic approach essential for accurate lymphoma classification and prognostication. This comprehensive strategy not only refines diagnosis but also informs staging and guides patient management, which we will explore in the next section. Understanding these molecular anchors empowers histotechnologists to contribute meaningfully to the diagnostic team, ensuring that laboratory findings translate into optimal clinical outcomes. As we transition into the critical topic of staging and prognosis, it is essential to appreciate how the laboratory report serves as a cornerstone in the clinical management of lymphoid neoplasms. In histotechnology, our role extends far beyond preparing slides. We are integral to a complex diagnostic workflow that ultimately informs treatment decisions and patient outcomes. Understanding the interplay between pathology findings and clinical staging systems is fundamental to fulfilling the goals of HTL 308, where we emphasize not only technical proficiency, but also interpretive insight and diagnostic collaboration. Staging systems such as Rye and Binet for chronic lymphocytic leukemia, CLL, and Ann Arbor or Lugano for Hodgkin and non-Hodgkin lymphomas rely heavily on accurate laboratory data. These systems stratify patients based on parameters including lymphocyte counts, hemoglobin levels, platelet counts, and the presence or absence of organomegaly or extranodal disease. For example, in CLL, the Rye system classifies patients into low, intermediate, and high-risk groups by assessing lymphocytosis alongside anemia and thrombocytopenia. This stratification guides clinicians in selecting appropriate risk-adapted therapies, balancing treatment intensity against potential toxicity. From a histotechnologist perspective, the integrity of the specimen is paramount. Proper specimen triage ensures that adequate tissue is allocated for morphology, immunohistochemistry, IHC, flow cytometry, and molecular studies. Fixation and decalcification protocols must be optimized to preserve antigenicity and nucleic acid quality, enabling reliable immunophenotyping and genetic testing. For instance, inadequate fixation can lead to weak or nonspecific IHC staining, complicating the interpretation of markers such as CD20, CD3, or Ki67, which are critical for subclassifying lymphomas and assessing proliferation rates. The Ki67 proliferation index is a particularly valuable prognostic marker, quantifying the fraction of tumor cells undergoing active division. Higher Ki67 indices correlate with more aggressive disease and poorer prognosis, influencing decisions about chemotherapy intensity. Similarly, molecular and cytogenetic analyses detect high-risk genetic abnormalities, such as TP53 mutations or double-hit rearrangements involving MYC and BCL2 or BCL6. These findings refine prognostic assessment beyond morphology and immunophenotype, underscoring the importance of integrating multiple laboratory modalities. The International Prognostic Index, IPI for diffuse large B-cell lymphoma, exemplifies how clinical features and laboratory parameters, including serum lactate dehydrogenase (LDH) levels, are combined to predict patient outcomes. Accurate laboratory reporting of morphology, immunophenotyping, and molecular results enables clinicians to apply these prognostic tools effectively. Any lapses in specimen handling, staining quality, or data interpretation can lead to misclassification, inappropriate therapy, and ultimately impact patient survival. In summary, the laboratory report is not a mere descriptive document. It is a dynamic clinical tool that shapes staging, prognosis, and treatment planning. As histotechnologists, our meticulous attention to specimen quality, staining reliability, and assay accuracy directly influences the diagnostic reasoning process and patient care. This understanding reinforces the critical nature of our work within the multidisciplinary team managing lymphoid neoplasms. With this foundation, we will next explore chronic lymphocytic leukemia and small lymphocytic lymphoma as a prototype mature B-cell leukemia, illustrating these principles in a clinical context. As we transition into the detailed study of mature B-cell leukemias, chronic lymphocytic leukemia and its tissue counterpart, small lymphocytic lymphoma, collectively referred to as CLL, SLL, serve as the prototype for this category of hematologic malignancies. Understanding CLL/SLL is essential not only because it is the most common mature B-cell neoplasm encountered in clinical practice, especially among older adults, but also because it exemplifies many of the diagnostic challenges and laboratory techniques integral to histotechnology and hematopathology. This slide introduces CLL/SLL by integrating key pathological, immunophenotypic, and epidemiologic features that are foundational for accurate diagnosis and effective laboratory workflow. From a pathological standpoint, CLL/SLL arises from a clonal proliferation of mature B lymphocytes. These cells typically present with a sustained lymphocytosis in peripheral blood or as lymphadenopathy in tissue biopsies, but without the aggressive clinical features seen in other lymphomas. Histologically, lymph node architecture in SLL is often effaced by small, mature-appearing lymphocytes with scant cytoplasm and clump chromatin, but these subtle morphological features require careful specimen handling and staining to appreciate fully. For histotechnologists, this underscores the importance of optimal fixation, usually formalin fixation for lymph node biopsies, and meticulous processing to preserve cellular detail. Decalcification is rarely necessary unless bone marrow biopsies are involved, where gentle protocols must be employed to maintain antigenicity for downstream immunohistochemical studies. Immunophenotyping is central to distinguishing CLL, SLL from other mature B-cell neoplasms, particularly mantle cell lymphoma, MCL, which can mimic CLL morphologically and clinically. The characteristic immunophenotype of CLL/SLL includes expression of pan-B-cell markers, such as CD19 and DIM-CD20, with aberrant co-expression of CD5, a marker typically associated with T cells, and CD23 positivity. Additionally, CD200 expression supports the diagnosis. Surface immunoglobulin expression is weak, reflecting the mature but functionally impaired nature of these neoplastic B cells. This immunophenotypic profile is routinely assessed by flow cytometry on peripheral blood or bone marrow aspirates, and by immunohistochemistry on tissue sections. Accurate immunostaining requires well-processed tissue sections and validated antibody panels, as false negatives or nonspecific staining can lead to diagnostic pitfalls. For example, mantle cell lymphoma also expresses CD5, but is negative for CD23 and positive for cyclin D1 due to the T11, 14, Q13, Q32 translocation, which is detectable by immunohistochemistry or molecular cytogenetic testing such as FISH. This distinction is critical because MCL generally has a more aggressive clinical course and different therapeutic implications. The slide also introduces monoclonal B-cell lymphocytosis, MBL, a precursor state characterized by low-level clonal B-cell populations that do not meet the threshold for CLL diagnosis and lack clinical symptoms. Recognizing MBL is important in the clinical laboratory because it may progress to overt CLL, but it does not require immediate treatment. From a histotechnology perspective, detecting MBL demands high sensitivity in flow cytometric analysis and careful gating strategies to identify small clonal populations. This highlights the importance of specimen triage and prioritization, ensuring that peripheral blood or bone marrow samples are collected and processed promptly to preserve cell viability and antigen expression. Finally, the epidemiologic context, illustrated by the age distribution graph on the slide, reminds us that CLL/SLL predominantly affects the elderly population. This demographic information guides clinical suspicion and specimen prioritization in the laboratory. In summary, this slide sets the stage for understanding CLL/SLL as a model mature B-cell leukemia, emphasizing the integration of morphology, immunophenotyping, molecular testing, and clinical context. Mastery of these concepts is essential for histotechnologists to contribute effectively to the diagnostic process, avoid common pitfalls, and support optimal patient care. The next section will build on this foundation by examining the peripheral blood morphology characteristic of CLL, further linking laboratory findings to clinical diagnosis. As we transition into the detailed examination of chronic lymphocytic leukemia, or CLL, peripheral blood morphology, it is essential to appreciate how this foundational knowledge integrates with the broader histotechnology workflow and diagnostic process. In HTL 308, our goal is not only to recognize morphological features, but to understand their significance in the context of specimen triage, processing, and downstream ancillary testing. Peripheral blood smears often serve as the initial window into a patient's hematologic status, and for diseases like CLL, the morphological clues can be subtle, yet highly informative. Chronic lymphocytic leukemia is characterized by a proliferation of small, mature-appearing lymphocytes in the peripheral blood. These lymphocytes display a distinctive morphology that, when carefully examined, provides critical diagnostic insight. The nuclei of these cells are typically round with densely clumped or block chromatin, which imparts a dark, homogeneous appearance under right-GM staining. The cytoplasm is scant and pale, contributing to the overall impression of small, uniform lymphocytes. This morphological uniformity is a hallmark of CLL, in contrast with the more heterogeneous appearance seen in other lymphoid neoplasms. One of the most diagnostically significant features in CLL peripheral blood smears is the presence of smudge cells, also known as basket cells. These are not intact lymphocytes, but rather nuclear remnants created when the fragile CLL lymphocytes rupture during the mechanical process of smear preparation. While smudge cells might initially be dismissed as mere artifacts, their abundance in a peripheral smear is a valuable diagnostic clue. For histotechnologists, recognizing smudge cells and understanding their origin is crucial, as these cells reflect the underlying fragility of the neoplastic lymphocytes and support the diagnosis of CLL in the appropriate clinical context. The quality of the peripheral blood smear is paramount in preserving these subtle morphological features. Poorly prepared smears can either exaggerate or obscure the presence of smudge cells, potentially leading to misinterpretation. This is where histotechnology techniques such as the albumin smear method come into play. By stabilizing fragile lymphocytes during smear preparation, albumin smears reduce the number of smudge cells and improve the clarity of cellular morphology. This technique exemplifies how histotechnologists directly impact diagnostic accuracy through meticulous specimen handling. Beyond morphology, the recognition of these characteristic lymphocytes and smudge cells on peripheral blood smears triggers a cascade of further diagnostic testing. Immunophenotyping by flow cytometry is typically the next step, confirming the clonal B-cell population and assessing markers such as CD5, CD19, CD20, and CD23. Molecular and cytogenetic studies may follow to evaluate prognostic markers like DEL17P or TP53 mutations. However, none of these advanced techniques would be appropriately targeted without the initial morphological suspicion raised by careful peripheral smear examination. In summary, mastering the peripheral blood morphology of CLL is a critical component of the histotechnologist's role in the diagnostic laboratory. It requires a keen eye for subtle cellular details, an understanding of artifact versus pathology, and an appreciation for how specimen preparation techniques influence diagnostic yield. This morphological foundation sets the stage for integrated diagnostic reasoning, guiding the selection of immunohistochemical panels, flow cytometry protocols, and molecular assays. As we proceed to the next slide, we will delve deeper into the nature of smudge cells and explore the albumin smear technique, further enhancing our ability to preserve and interpret these important morphological features. As we continue our exploration of mature lymphoid neoplasms, this slide delves into a distinctive morphological feature encountered in chronic lymphocytic leukemia, or CLL, the presence of smudge cells in peripheral blood smears, and introduces the albumin smear technique as a valuable tool to enhance morphological assessment. Understanding these elements is essential for histotechnologists, because the quality of smear preparation and the preservation of cellular detail directly influence diagnostic accuracy and downstream ancillary testing. Smudge cells, also known as basket cells, are a hallmark finding in CLL peripheral blood smears. These cells represent fragile lymphocytes that rupture during the mechanical stress of smear preparation, leaving behind nuclear remnants that lack cytoplasm. While they may initially appear as nonspecific artifacts or debris, their consistent presence in a blood smear is a significant diagnostic clue when correlated with clinical presentation and immunophenotypic data obtained from flow cytometry. It is crucial to emphasize that smudge cells themselves are not malignant cells, but rather disrupted remnants of the leukemic lymphocytes, reflecting the inherent fragility of these neoplastic cells. From a histotechnologist's perspective, the formation of smudge cells presents a diagnostic challenge. Excessive smudging can obscure the morphology of intact lymphocytes, making it difficult to evaluate key features such as nucleochromatin pattern, nucleoli, and cytoplasmic characteristics that are vital for differentiating CLL from other lymphoproliferative disorders. This is where the albumin smear technique becomes invaluable. By mixing a small volume of albumin with the blood sample prior to smear preparation, the albumin acts as a protective medium that stabilizes the lymphocytes. This reduces cellular rupture during the spreading process, resulting in fewer smudge cells and better preservation of cellular morphology. The improved quality of smears prepared with albumin facilitates more accurate morphological evaluation, which is critical not only for initial diagnosis, but also for guiding subsequent ancillary studies. For example, clearer cellular details support more precise immunohistochemical staining on bone marrow biopsies or lymph node specimens, and they enhance the reliability of flow cytometric immunophenotyping by confirming the presence of characteristic CLL cell populations. Furthermore, well-preserved morphology aids molecular and cytogenetic testing by ensuring that the specimen is representative and not compromised by artifact. In practice, mastering the albumin smear technique requires attention to specimen triage and workflow. Histotechnologists must coordinate closely with hematology and pathology colleagues to ensure that peripheral blood samples are handled promptly and appropriately, minimizing delays that could affect cell viability. Proper fixation and staining protocols must be followed meticulously to maintain cellular integrity and optimize visualization of subtle morphological features. In summary, recognizing smudge cells and employing the albumin smear technique exemplify how histotechnologists contribute to the diagnostic process in hematopathology. By reducing artifact and enhancing morphological clarity, these practices improve diagnostic confidence and facilitate comprehensive evaluation of CLL. As we move forward, we will build on this foundation by examining bone marrow involvement in CLL and the integration of morphology with immunophenotypic and molecular data to achieve a definitive diagnosis. As we transition into the critical topic of chronic lymphocytic leukemia, CLL, involvement in the bone marrow, and the essential ancillary workup, it is important to appreciate how this integrates with the broader goals of HTL 308. Our focus here is not merely on recognizing morphologic features under the microscope, but on understanding the entire histotechnology workflow that supports accurate diagnosis, prognostication, and ultimately patient management. Bone marrow biopsies in suspected CLL cases present unique challenges and opportunities for histotechnologists, pathologists, and laboratory scientists alike. The specimen triage process, fixation protocols, decalcification methods, and staining quality all directly impact the ability to interpret marrow morphology and perform downstream ancillary studies, such as immunohistochemistry, flow cytometry, and molecular cytogenetics. CLL is a mature B-cell neoplasm characterized by clonal proliferation of small, mature-appearing lymphocytes. Bone marrow involvement is a common and diagnostically significant feature, often manifesting as lymphoid infiltrates that can be nodular, interstitial, or diffuse. Recognizing these patterns requires careful histologic examination of well-fixed, properly decalcified marrow core biopsies. Over or under decalcification can obscure nuclear detail or compromise antigenicity, which in turn affects immunohistochemical staining quality. For example, CD20 and CD5 immunostains are critical to confirm the B-cell lineage and aberrant co-expression of T-cell markers typical of CLL. Poor fixation or decalcification can lead to weak or patchy staining, complicating interpretation. Beyond morphology and immunohistochemistry, flow cytometry plays a pivotal role in confirming the diagnosis. Fresh bone marrow aspirate must be promptly delivered to the flow lab to preserve cell viability. The characteristic immunophenotype of CLL cells includes expression of PAM-B markers such as CD19 and DIM-CD20, co-expression of CD5 and CD23, and weak surface immunoglobulin light chains. The absence of FMC7 expression helps distinguish CLL from other B-cell neoplasms like mantle cell lymphoma. Histotechnologists must coordinate closely with clinical teams to ensure appropriate specimen handling and timely transport, as delays or improper anticoagulation can lead to cell degradation and unreliable results. Cytogenetic analysis, particularly fluorescence in situ hybridization, FISH, provides critical prognostic information that guides clinical management. The most common cytogenetic abnormality in CLL is deletion of 13q14, which is associated with a favorable prognosis. Other abnormalities such as deletion of 11q22 to 23 or trisomy 12 carry intermediate risk, while TP53 mutations or complex karyotypes indicate poor prognosis and may prompt more aggressive therapy. Performing FISH requires well-preserved interphase nuclei, which depends on optimal fixation and processing of marrow aspirate or biopsy touch preparations. Histotechnologists must be aware of these requirements to avoid artifacts that could lead to false negative or false positive results. In summary, the diagnosis and prognostication of CLL in bone marrow specimens rely on a multidisciplinary approach that integrates morphology, immunophenotyping, flow cytometry, and cytogenetics. Each step, from specimen collection and fixation to staining and ancillary testing, must be meticulously executed to ensure diagnostic accuracy. Understanding these processes and potential pitfalls enhances your ability as histotechnologists to contribute meaningfully to patient care. In the next section, we will explore entities that mimic CLL morphologically and immunophenotypically, highlighting common diagnostic pitfalls and strategies to avoid them. As we transition into the critical topic of differential diagnosis in chronic lymphocytic leukemia, or CLL, it is essential to appreciate the nuanced distinctions among related lymphoid disorders that can present with overlapping clinical and pathological features. Accurate differentiation is not merely an academic exercise. It directly impacts patient management, prognosis, and therapeutic decisions. For histotechnologists, understanding these differences informs specimen triage, fixation protocols, staining strategies, and the selection of ancillary studies such as immunohistochemistry, flow cytometry, and molecular testing. This slide focuses on 4 entities that frequently enter the differential diagnosis of CLL: monoclonal B-cell lymphocytosis, MBL, small lymphocytic lymphoma, SLL, mantle cell lymphoma, MCL, and reactive lymphocytosis. Each of these conditions shares some morphological or immunophenotypic characteristics with CLL, but differs in clinical presentation, biological behavior, and genetic features. Recognizing these distinctions requires a comprehensive approach integrating morphology, immunophenotyping, cytogenetics, and clinical context. Starting with MBL, this entity is characterized by the presence of a clonal B-cell population in the peripheral blood, but at levels below the diagnostic threshold for CLL, specifically less than 5 × 10 to the 9 per liter lymphocytes, and without any clinical symptoms or organ involvement. From a histotechnological perspective, specimens from MBL cases often come from peripheral blood or bone marrow aspirates, where careful preparation and staining are crucial to detect subtle clonal populations. Immunophenotypic analysis via flow cytometry is indispensable here, as it confirms clonality and helps distinguish MBL from reactive processes. Importantly, MBL is considered a precursor state to CLL but does not warrant treatment, underscoring the need for precise diagnosis to avoid overtreatment. Small lymphocytic lymphoma, or SLL, represents the tissue-based counterpart of CLL. Unlike CLL, which primarily involves peripheral blood and bone marrow, SLL presents with lymphadenopathy and minimal or absent peripheral blood lymphocytosis. Morphologically and immunophenotypically, SLL and CLL are virtually indistinguishable. Both show small, mature-appearing lymphocytes with scant cytoplasm, and a characteristic immunophenotype expressing CD5 and CD23. For histotechnologists, processing lymph node biopsies in suspected SLL cases requires meticulous fixation and sectioning to preserve architecture and cellular detail. Immunohistochemistry panels are critical to confirm the diagnosis and exclude other lymphomas. Mantle cell lymphoma poses a significant diagnostic challenge because it also expresses CD5, a marker commonly associated with CLL. However, MCL lacks CD23 expression and, importantly, shows overexpression of cyclin D1 due to the characteristic T11, 14, Q13, Q32 translocation. This cytogenetic hallmark is detected through fluorescence in situ hybridization, FISH, or molecular assays. From a histotechnology standpoint, ensuring optimal fixation and antigen preservation is vital for reliable cyclin D1 immunostaining. Misclassifying MCL as CLL can have serious consequences because MCL typically follows a more aggressive clinical course and requires different treatment protocols. Lastly, reactive lymphocytosis must be considered, especially in patients with recent infections or immune stimulation. Unlike the clonal expansion seen in CLL and related neoplasms, reactive lymphocytosis features polyclonal lymphocytes without clonal markers or cytogenetic abnormalities. Morphologically, reactive lymphocytes are often larger, with more abundant cytoplasm and prominent nucleoli, reflecting their activated state. Recognizing these features prevents misdiagnosis and unnecessary interventions. In the laboratory, flow cytometry, demonstrating polyclonality and the absence of aberrant immunophenotypic markers, supports a reactive process. In summary, this comparative framework underscores the importance of integrating clinical information, morphological assessment, immunophenotyping, and cytogenetic testing to accurately distinguish CLL from its mimics. For histotechnologists, attention to specimen quality, appropriate staining protocols, and collaboration with the clinical team are essential to avoid diagnostic pitfalls. Mastery of these concepts aligns directly with our learning goals in HTL 308, equipping you to contribute effectively to the diagnosis of mature lymphoid NE. As we transition into the topic of prolymphocytic leukemia, or PLL, it is crucial to appreciate how this rare but aggressive mature lymphoid leukemia challenges both diagnostic acumen and histotechnology workflow. PLL exemplifies the critical intersection of morphology, clinical data, and ancillary testing that defines advanced hematopathology practice. For histotechnologists, understanding PLL's distinctive features is not merely academic. It directly impacts specimen triage, fixation protocols, staining quality, and the selection of appropriate immunohistochemical and molecular assays that guide patient care. PLL must be carefully distinguished from chronic lymphocytic leukemia, CLL, a more common and typically indolent lymphoid neoplasm. Although both diseases involve mature lymphocytes, their clinical courses, treatment strategies, and prognoses differ dramatically. This distinction begins with peripheral blood smear evaluation, where histotechnologists play a frontline role. PLL characteristically presents with very high white blood cell counts, often exceeding 100 × 10 to the 9 per liter, and pronounced splenomegaly. Unlike CLL, lymphadenopathy is usually minimal or absent, a clinical clue that should prompt heightened suspicion when correlated with morphology. Morphologically, PLL cells are notably larger than typical CLL lymphocytes, approximately twice the size, and exhibit more abundant cytoplasm. The chromatin pattern is more open or moderately condensed, contrasting with the dense, clumped chromatin of CLL cells. Most importantly, PLL cells display a single, prominent nucleolus, a feature absent in CLL. This nucleolus is a key diagnostic hallmark, signaling a more aggressive neoplasm and underscoring the importance of meticulous slide preparation and staining quality to preserve nuclear detail. Poor fixation or suboptimal staining can obscure this critical feature, leading to diagnostic pitfalls. The T-cell variant of PLL, known as TPLL, adds another layer of complexity. These cells often have irregular or cerebriform nuclear contours and express the TCL1 protein, frequently associated with the INV 14, Q11, Q32 chromosomal abnormality. Recognizing TPLL requires integration of morphology, immunophenotyping, often via flow cytometry, and cytogenetic or molecular testing. For histotechnologists, ensuring that bone marrow biopsies and peripheral blood specimens are properly fixed and processed is essential to enable these downstream analyses. In the histotechnology laboratory, prompt identification of prolymphocytes on peripheral blood smears or bone marrow aspirates should trigger immediate communication with the hematopathologist. This facilitates urgent diagnostic workup and timely initiation of therapy, which is critical given PLL's aggressive nature. As we study PLL, keep in mind the broader learning goals of HTL 308, mastering the morphologic subtleties of mature lymphoid neoplasms, understanding how specimen handling affects diagnostic accuracy, and appreciating the role of ancillary techniques in confirming challenging diagnoses. With this foundation, you will be well prepared to differentiate PLL from other lymphoid leukemias and lymphomas, avoiding common pitfalls such as misclassifying PLL as CLL due to overlapping features. In the next segment, we will explore hairy cell leukemia, an indolent B-cell neoplasm with its own distinctive clinical and morphologic profile, further expanding your diagnostic repertoire in mature lymphoid disorders. As we transition into the topic of hairy cell leukemia, or HCL, it is essential to appreciate how this unique lymphoid neoplasm exemplifies the critical intersection of clinical presentation, morphology, and advanced laboratory diagnostics, a core focus of our HTL 308 curriculum. Hairy cell leukemia is classified as an indolent mature B-cell neoplasm, predominantly affecting middle-aged men, and it challenges histotechnologists and pathologists alike due to its distinctive features and diagnostic nuances. Understanding HCL not only reinforces our grasp of mature lymphoid neoplasms, but also sharpens our skills in specimen triage, fixation protocols, staining techniques, and the integration of immunophenotypic and molecular data to reach an accurate diagnosis. Clinically, patients with HCL often present with pancytopenia, notably neutropenia and monocytopenia, coupled with splenomegaly. Unlike many other lymphoid malignancies, significant lymphadenopathy is typically absent, which can initially obscure the diagnosis. This clinical profile directs the laboratory workflow toward bone marrow evaluation, where the hallmark features of HCL become apparent. However, the marrow involvement is complicated by reticulin fibrosis, frequently leading to a dry tap during aspiration. This scenario underscores the importance of obtaining a core biopsy specimen and highlights the histotechnologist's role in ensuring optimal fixation and processing to preserve tissue architecture and enable reliable reticulin staining. Reticulin stains are indispensable here as they reveal the degree of marrow fibrosis, a critical diagnostic clue that also impacts specimen handling and interpretation. Morphologically, the peripheral blood smear reveals the characteristic hairy cells, mature B lymphocytes with oval or reniform nuclei, and diffuse, mature chromatin. Their pale blue cytoplasm is fringed with circumferential, ragged cytoplasmic projections, giving rise to the eponymous hairy appearance. This morphology is often likened to a fried egg due to the cytoplasmic halo surrounding the nucleus, a descriptive term that aids in visual recognition. For histotechnologists, maintaining staining quality, whether with Romanowski-type stains on peripheral smears or hematoxylin and eosin on marrow biopsies, is critical to preserving these subtle cytoplasmic details that are diagnostically informative. Immunophenotyping further refines the diagnosis. Hairy cells express a distinctive panel of markers, including pan-B cell antigens such as CD19, CD20, and CD22, alongside more specific markers like CD11C, CD25, CD103, CD123, and annexin A1. Tartrate-resistant acid phosphatase, TRAP, positivity, historically significant, is now supplemented by flow cytometry and immunohistochemistry panels that provide rapid and reliable confirmation. Molecular testing for the BRAF Vi600E mutation, present in the majority of classic HCL cases, has become a cornerstone of diagnosis and therapeutic targeting. This molecular insight exemplifies the evolving role of histotechnology in supporting advanced molecular assays, requiring meticulous specimen preservation and coordination with molecular pathology laboratories. In summary, hairy cell leukemia serves as a paradigm of how an indolent yet distinctive hematologic malignancy demands a comprehensive, multidisciplinary diagnostic approach. For histotechnologists, it reinforces the importance of specimen triage, fixation, staining quality, and the integration of immunophenotypic and molecular data. Mastery of these elements not only facilitates accurate diagnosis but also directly impacts patient management, as early recognition enables timely initiation of effective therapies such as purine analogs, which can induce durable remissions. As we proceed, we will delve deeper into the morphological subtleties of hairy cells and explore the diagnostic challenges posed by marrow fibrosis, further enhancing your expertise in the laboratory diagnosis of mature lymphoid neoplasms. As we transition into the detailed study of hairy cell leukemia, this slide focuses on two interrelated aspects that are critical for both diagnostic accuracy and laboratory workflow: the distinctive morphology of hairy cells and the frequent occurrence of the dry tap phenomenon during bone marrow aspiration. Understanding these features is essential not only for recognizing the disease under the microscope, but also for anticipating and overcoming common pitfalls in specimen collection and processing that can impact downstream testing. Hairy cell leukemia is a mature B-cell lymphoid neoplasm characterized by a unique cellular morphology that sets it apart from other lymphoproliferative disorders. The hallmark cells, aptly named hairy cells, exhibit oval to reniform nuclei with mature condensed chromatin and typically lack prominent nucleoli. This nuclear appearance reflects their mature lymphoid origin and helps differentiate them from blasts or other immature cells. Surrounding the nucleus is a pale blue cytoplasm that is notable for fine, circumferential cytoplasmic projections. These hairy projections are slender, filamentous extensions that give the cells their characteristic appearance. These projections are best appreciated on well-prepared peripheral blood smears or bone marrow touch preparations, where cell morphology is preserved without distortion. In bone marrow biopsy sections, the cells often display a fried egg appearance, where the cytoplasm appears clear and expansive around the nucleus. This effect is partly an artifact of fixation and processing, but also reflects the abundant cytoplasm of these cells. One of the most significant diagnostic challenges in hairy cell leukemia arises from the frequent presence of marrow fibrosis. The neoplastic hairy cells stimulate reticulin fiber deposition within the marrow stroma, leading to a dense fibrotic network. This fibrosis physically impedes the aspiration of marrow cells, resulting in what is clinically termed a dry tap, where the aspirate yields little or no cellular material. For histotechnologists and laboratory personnel, this dry tap is a critical red flag that necessitates reliance on core biopsy specimens rather than aspirates for diagnosis. The core biopsy provides an intact architectural context and allows for reticulin staining, which highlights the extent of fibrosis. Reticulin stains are indispensable in confirming marrow fibrosis, as they reveal the dense meshwork of fibers that correlates with the aspiration failure. From a histotechnology perspective, specimen triage and processing are crucial. When a dry tap is encountered, prompt preparation of high-quality bone marrow core biopsies is essential. Proper fixation, usually with neutral buffered formalin or other appropriate fixatives, and decalcification protocols must be carefully optimized to preserve cellular morphology and antigenicity. This preservation is vital for subsequent immunohistochemical studies, which are often required to confirm the diagnosis by demonstrating the characteristic immunophenotype of hairy cells, including markers such as CD103, CD25, and annexin A1. Furthermore, molecular and cytogenetic testing may be performed on biopsy material or peripheral blood to detect mutations like BRAF5600E, which has diagnostic and therapeutic implications. In summary, the morphology of hairy cells and the associated marrow fibrosis that leads to dry tap aspiration are intimately linked challenges in the diagnosis of hairy cell leukemia. Recognizing these features guides the histotechnologist in specimen handling and processing, ensuring that adequate material is available for comprehensive diagnostic workup. This understanding also underscores the importance of integrating morphological assessment with immunophenotypic and molecular data to arrive at a definitive diagnosis and inform patient management. As we proceed, we will delve deeper into the immunophenotypic profiles and molecular characteristics that define hairy cell leukemia, further refining our diagnostic approach and highlighting the critical role of the histotechnology laboratory in this process. As we transition into the detailed ancillary profile of hairy cell leukemia, it is crucial to appreciate how this knowledge integrates with the broader goals of HTL 308, particularly in mastering the diagnostic workflow for mature lymphoid neoplasms. Hairy cell leukemia, HCL, presents a unique challenge in pathology and histotechnology due to its overlapping morphological features with other B-cell lymphoproliferative disorders and the necessity for precise immunophenotypic and molecular characterization. Understanding the ancillary profile of HCL not only sharpens your diagnostic acumen, but also highlights the critical role of specimen triage, fixation, staining quality, and the judicious use of ancillary studies such as flow cytometry, immunohistochemistry, and molecular testing. Morphologically, hairy cells are identified by the characteristic cytoplasmic projections, but morphology alone is insufficient for definitive diagnosis. This is where the ancillary profile becomes indispensable. Hairy cells express a distinct panel of surface markers, including CD11C, CD25, CD103, and CD123, which are routinely assessed by flow cytometry. Among these, CD25 and CD103 are particularly informative, as their co-expression strongly supports a diagnosis of classic HCL. The flow cytometry dot plots you see on the left side of the slide demonstrate this co-expression pattern, which helps differentiate HCL from other B-cell neoplasms that may lack one or both markers. Immunohistochemistry further complements flow cytometry by allowing visualization of protein expression within tissue architecture. Annexin A1 stands out as a highly specific marker for classic HCL. Its presence is invaluable in distinguishing classic HCL from the hairy cell leukemia variant and splenic marginal zone lymphoma, both of which lack annexin A1 expression. This specificity makes annexin A1 a cornerstone in the immunohistochemical panel for suspected HCL cases. Additionally, tartrate-resistant acid phosphatase, TRAP staining, historically a hallmark enzymatic stain for HCL, remains a useful adjunct, although it has largely been supplanted by immunophenotyping due to issues with reproducibility and specificity. Nonetheless, TRAP positivity can still provide supportive evidence, especially in resource-limited settings. Molecular testing has revolutionized the diagnostic landscape for HCL. The BRAF V600E mutation is present in the vast majority of classic HCL cases and serves as both a definitive diagnostic marker and a therapeutic target. Detection of this mutation confirms the diagnosis and opens the door to targeted therapies, which have significantly improved patient outcomes. Importantly, the BRAF V600E mutation is absent in the hairy cell leukemia variant and other mimics, underscoring the necessity of comprehensive molecular profiling to avoid misdiagnosis and inappropriate treatment. From a histotechnologist's perspective, the ancillary profile of HCL underscores the importance of meticulous specimen handling. Proper fixation and processing are essential to preserve antigenicity for both flow cytometry and immunohistochemistry. Coordinating with the clinical laboratory to ensure timely and appropriate molecular testing is equally critical. Awareness of potential pitfalls, such as antigen degradation or suboptimal staining, can prevent diagnostic delays and errors. In summary, the diagnosis of hairy cell leukemia relies on an integrated approach combining morphology, immunophenotyping, and molecular studies. This multi-parameter strategy ensures accurate classification, informs prognosis, and guides targeted therapy. As you review the flow cytometry and immunohistochemistry images on this slide, focus on how these data complement each other and reinforce the importance of a coordinated laboratory workflow. Next, we will explore large granular lymphocytic leukemia, another mature lymphoid neoplasm, with distinctive features and diagnostic considerations that further expand your understanding of hematopathology and histotechnology. As we transition into the topic of large granular lymphocytic leukemia, or LGL leukemia, it is essential to appreciate how this entity exemplifies the integration of morphology, immunophenotyping, molecular diagnostics, and clinical correlation, core competencies in histotechnology and hematopathology. LGL leukemia is a chronic lymphoproliferative disorder characterized by the clonal expansion of large lymphocytes that contain distinctive cytoplasmic granules. These granules are not merely morphological curiosities. They represent cytotoxic granules, reflecting the functional phenotype of the neoplastic cells, which can be of either T-cell or natural killer NK cell lineage. This dual lineage origin underscores the importance of precise immunophenotypic characterization, a process in which histotechnologists play a pivotal role by preparing and preserving specimens that allow for accurate downstream testing. From a pathology standpoint, the hallmark large granular lymphocytes are morphologically identifiable by their abundant pale cytoplasm filled with azurophilic granules. These granules correspond to cytotoxic lysosomes loaded with enzymes such as perforin and granzyme B, which mediate target cell apoptosis. Recognizing these features on peripheral blood smears or bone marrow aspirates requires meticulous specimen triage and fixation protocols to preserve cytoplasmic detail. For example, air-dried peripheral blood smears stained with right Giemsa are optimal for visualizing these granules, whereas formalin fixation of bone marrow biopsies must be carefully controlled to prevent loss of antigenicity for immunohistochemical stains. Immunophenotyping is indispensable in distinguishing T-cell LGL leukemia from NK cell LGL leukemia and from reactive LGL expansions. T-cell LGL leukemia cells typically express surface markers CD3, CD8, and CD57, with clonal T-cell receptor TCR gene rearrangements confirming their monoclonality. In contrast, NK cell LGL leukemia lacks surface CD3, but expresses CD56 and other NK markers. Reactive LGL expansions, which may occur transiently in autoimmune diseases, infections, or post-transplant settings, are polyclonal and lack these clonal rearrangements. This distinction is critical because reactive expansions often resolve spontaneously, whereas clonal LGL leukemia requires clinical intervention. Histotechnologists must ensure that specimens are appropriately processed for flow cytometry and molecular studies, including TCR gene rearrangement assays, to facilitate this differentiation. Clinically, patients with LGL leukemia often present with cytopenias, most notably neutropenia and anemia, which can lead to recurrent infections and fatigue. Autoimmune phenomena, such as rheumatoid arthritis, are frequently associated, highlighting the interplay between neoplastic proliferation and immune dysregulation. The disease predominantly affects older adults and usually follows an indolent course, although some cases may progress or require treatment with immunosuppressive agents. In the histotechnology workflow, maintaining high staining quality and antigen preservation is paramount. Immunohistochemistry panels, including CD3, CD8, CD57, CD56, and cytotoxic markers like granzyme B or TIA1 provide critical diagnostic clues. Flow cytometry complements these findings by allowing rapid multiparametric analysis of cell surface and intracellular markers, while molecular and cytogenetic testing confirm clonality and exclude other mature lymphoid neoplasms. Common pitfalls include misinterpreting reactive LGL expansions as leukemia, which can lead to overtreatment, or failing to recognize subtle cytoplasmic granules due to suboptimal smear preparation or staining. Therefore, rigorous attention to specimen handling, fixation, and staining protocols is essential to avoid diagnostic errors. By systematically comparing the morphological, immunophenotypic, and clinical features of T-cell and NK cell LGL leukemias alongside reactive expansions, we deepen our diagnostic reasoning skills. This integrated approach is vital for accurate diagnosis and appropriate patient management. As we conclude this section, keep in mind the importance of correlating laboratory findings with clinical presentation and the necessity of multidisciplinary collaboration in managing complex lymphoproliferative disorders. Next, we will examine adult T-cell leukemia/lymphoma, focusing on the characteristic flower cells that define its leukemic phase, further expanding our understanding of mature lymphoid neoplasms and their diverse presentations. As we transition into the topic of adult T-cell leukemia/lymphoma, or ATLL, it is essential to appreciate how this mature T-cell neoplasm exemplifies the critical intersection of pathology, histology, and advanced laboratory diagnostics in hematopathology. ATLL is a unique and aggressive malignancy etiologically linked to infection with human T-cell lymphotropic virus type 1, or HTLV1. This viral association not only influences the disease's geographic distribution, but also shapes its clinical presentation and laboratory evaluation. For histotechnologists, understanding the morphological hallmarks of ATLL and the appropriate specimen handling protocols is vital for accurate diagnosis and subsequent patient management. The defining cytological feature of ATLL in the leukemic phase is the presence of so-called flower cells in peripheral blood smears. These atypical lymphocytes exhibit deeply multilobulated, convoluted nuclei that resemble flower petals, a morphology that is pathognomonic for this disease. The nuclear chromatin is characteristically clumped, and the cytoplasm is moderately basophilic. Preserving these delicate nuclear contours during smear preparation requires meticulous technique. Rapid drying and gentle spreading are necessary to avoid artifactual distortion of the nuclear lobulations, which could obscure this diagnostic clue. Fixation protocols must balance cellular preservation with antigenicity retention, especially when subsequent immunohistochemical or flow cytometric studies are anticipated. From a specimen triage perspective, peripheral blood samples suspected of HTL should be promptly processed to enable comprehensive evaluation. Immunophenotyping by flow cytometry is indispensable, as it confirms the mature T-cell lineage and often reveals aberrant expression patterns, such as loss of CD7 or CD26, which help distinguish HTL from other mature T-cell neoplasms. Concurrent serologic testing for HTLV1 antibodies is critical to establish the viral etiology, which has implications for prognosis and epidemiology. In cases where lymph node or skin biopsies are available, formalin fixation and paraffin embedding must be optimized to preserve morphology and antigenicity for immunohistochemistry, including markers like CD3, CD4, and CD25. Molecular and cytogenetic analyses can further characterize the clonal T-cell receptor gene rearrangements and detect chromosomal abnormalities that may guide therapeutic decisions. However, these advanced tests depend on high-quality nucleic acid extraction, which in turn relies on proper tissue fixation and processing protocols. Common pitfalls include overfixation, which can degrade nucleic acids, and underfixation, which compromises morphology and immunostaining quality. Clinically, HTL often presents with extranodal involvement, particularly cutaneous lesions, and systemic symptoms such as hypercalcemia and profound immunosuppression. These features underscore the importance of integrating clinical data with laboratory findings to avoid misdiagnosis. For example, the presence of flower cells in peripheral blood should prompt consideration of HTL in patients from endemic regions like southwestern Japan, the Caribbean, or parts of Africa, where HTLV1 prevalence is higher. In summary, recognizing the characteristic flower cells on peripheral blood smears is a cornerstone of HTL diagnosis. This morphological insight, combined with immunophenotyping, serology, and molecular studies, forms a comprehensive diagnostic approach. As histotechnologists, your role in specimen preparation, staining quality, and facilitating ancillary testing is crucial to ensuring accurate and timely diagnosis. Mastery of these concepts will enhance your diagnostic reasoning skills and prepare you for the complexities of mature lymphoid neoplasms encountered in clinical practice. Next, we will explore the leukemic phases of other lymphomas and the diagnostic challenges they present in peripheral blood evaluation. As we transition to the topic of lymphoma entering the blood, it is essential to appreciate the diagnostic complexities that arise when malignant lymphoid cells spill over from their usual tissue compartments into the peripheral circulation. This phenomenon, often referred to as the leukemic phase of lymphoma, represents a critical juncture in patient evaluation and management, demanding a nuanced understanding of pathology, histology, and laboratory techniques from the histotechnologist's perspective. Lymphomas, particularly non-Hodgkin lymphomas such as follicular lymphoma and mantle cell lymphoma, typically manifest within lymph nodes or extranodal tissues. However, in certain cases, these malignant cells gain access to the bloodstream, where they may circulate as abnormal lymphoid cells. This transition complicates diagnosis because lymphoma cells in peripheral blood can closely mimic normal or reactive lymphocytes, challenging even experienced observers. Automated hematology analyzers may flag these cells as abnormal lymphocytes, but definitive identification relies heavily on meticulous peripheral blood smear review. Here, the histotechnologist's role is pivotal. Preparing high-quality smears with optimal fixation and staining is crucial to preserve subtle morphological details that distinguish neoplastic cells from benign counterparts. Morphological evaluation focuses on discerning differences in cell size, nuclear chromatin pattern, nucleolar prominence, and cytoplasmic characteristics. For example, lymphoma cells may exhibit irregular nuclear contours, coarser chromatin, or more prominent nucleoli compared to reactive lymphocytes. Recognizing these features requires not only technical skill in slide preparation, but also a deep understanding of lymphoid cell morphology and its variations in disease states. Accurate identification and quantification of circulating lymphoma cells are vital for staging, prognosis, and monitoring therapeutic response, underscoring the importance of precise histotechnological practices. Beyond morphology, ancillary studies such as immunophenotyping by flow cytometry and molecular or cytogenetic testing play indispensable roles in confirming clonality and defining lymphoma subtypes. The histotechnologist facilitates these processes by ensuring proper specimen triage, maintaining sample integrity, and coordinating timely processing. Immunohistochemistry on peripheral blood or bone marrow biopsies complements flow cytometry by localizing antigen expression within tissue architecture, further refining diagnosis. The flowchart presented on this slide encapsulates a systematic diagnostic approach, starting with morphological assessment, advancing through immunophenotypic characterization, and integrating clinical data to reach a definitive diagnosis. This integrated strategy helps avoid common pitfalls, such as misclassifying reactive lymphocytosis as lymphoma or overlooking subtle leukemic involvement. It also ensures that clinicians receive comprehensive, accurate reports that guide appropriate therapeutic decisions. As we delve deeper into specific entities, we will next examine Burkitt leukemia/lymphoma, a high-grade lymphoma with distinctive cytological and molecular features that demand urgent and precise diagnosis. Understanding the principles outlined here lays the foundation for recognizing and managing such aggressive lymphoid neoplasms when they enter the bloodstream. As we delve into the high-grade pattern recognition of Burkitt leukemia and lymphoma, it is essential to appreciate the critical role histotechnologists play in the accurate and timely diagnosis of this aggressive mature B-cell neoplasm. Burkitt lymphoma is a hematopathologic emergency characterized by its rapid proliferation and fulminant clinical course, making the quality of specimen processing and diagnostic workflow paramount. Understanding the morphological, immunophenotypic, and molecular hallmarks of this disease not only enhances diagnostic precision, but also directly impacts patient management and outcomes. Morphologically, Burkitt lymphoma cells are distinctive and recognizable under the microscope. They are typically medium to large in size, with round nuclei that contain multiple prominent nucleoli. One of the most striking features is the abundant cytoplasm, filled with numerous lipid vacuoles, which impart a foamy or bubbly appearance. This cytoplasmic vacuolation is a key diagnostic clue, especially when examining peripheral blood smears or bone marrow aspirates. From a histotechnological perspective, preserving these delicate cytoplasmic features requires meticulous fixation and processing. Overfixation or harsh decalcification protocols can obscure these vacuoles, potentially leading to diagnostic confusion with other high-grade lymphomas or leukemias. Immunophenotypically, Burkitt lymphoma cells express pan-B cell markers such as CD19 and CD20, alongside germinal center markers like CD10 and CD38. Notably, these cells are negative for terminal deoxynucleotidyltransferase, TDT, and BCL2, which helps distinguish Burkitt lymphoma from other lymphoid neoplasms, including lymphoblastic leukemia and follicular lymphoma. For histotechnologists, ensuring optimal antigen preservation during fixation and embedding is critical to achieving reliable immunohistochemical staining. Suboptimal fixation can lead to weak or nonspecific staining, complicating the interpretation of these key markers. At the molecular level, the defining hallmark of Burkitt lymphoma is the MYC gene rearrangement, most commonly the T8, 14, Q24, Q32 translocation involving the immunoglobulin heavy chain locus. This genetic alteration drives the tumor's aggressive biology by deregulating MYC oncogene expression, resulting in uncontrolled cellular proliferation. The nearly 100% Ki67 proliferation index observed in Burkitt lymphoma reflects this hyperproliferative state, with almost all tumor cells actively cycling. From a laboratory standpoint, accurate assessment of Ki67 requires well-preserved nuclear morphology and standardized staining protocols to avoid under- or overestimation of proliferative activity. In terms of workflow, histotechnologists must prioritize rapid specimen triage and processing to facilitate timely immunohistochemical, flow cytometric, and molecular analyses. Bone marrow biopsies and lymph node excisions suspected of harboring Burkitt lymphoma should be fixed promptly in neutral buffered formalin, avoiding prolonged fixation or decalcification that could compromise nucleic acid integrity. When decalcification is necessary, using EDTA-based solutions rather than strong acids preserves DNA quality for fluorescence, in situ hybridization, FISH, and polymerase chain reaction, PCR, assays that detect MYC rearrangements. Flow cytometry complements immunohistochemistry by providing rapid immunophenotypic profiling, and molecular cytogenetic testing confirms the diagnosis, guiding therapeutic decisions. Diagnostic pitfalls include confusing Burkitt lymphoma with other high-grade B-cell lymphomas or lymphoblastic leukemia, especially when cytoplasmic vacuolation is subtle or immunophenotypic profiles overlap. Awareness of the characteristic morphology, immunophenotype, and molecular genetics is essential to avoid misclassification. Furthermore, inadequate fixation or poor slide quality can obscure these features, underscoring the histotechnologist's vital role in specimen handling. In summary, recognizing the high-grade pattern of Burkitt leukemia/lymphoma requires integration of morphological clues, immunophenotypic markers, and molecular findings. Histotechnologists are integral to this process, ensuring specimen integrity and facilitating rapid, accurate diagnosis. This slide encapsulates the urgency and complexity of Burkitt lymphoma diagnosis, reinforcing the importance of pattern recognition and multidisciplinary collaboration in managing mature lymphoid neoplasms. As we move forward, we will contrast this. As we delve into follicular lymphoma on this slide, it is essential to appreciate how this neoplasm exemplifies the intersection of pathology, histology, and histotechnology in the diagnosis and management of mature B-cell lymphomas. Follicular lymphoma is a paradigmatic indolent lymphoma arising from germinal center B cells, and its recognition hinges on a detailed understanding of nodal architecture, immunophenotypic markers, and molecular genetics. For histotechnologists, mastering the nuances of specimen handling, fixation, and staining is critical to preserving the delicate follicular patterns and antigen expression that underpin accurate diagnosis. Histologically, follicular lymphoma recapitulates the germinal center's nodular architecture, forming discrete follicles composed predominantly of neoplastic centrocytes and centroblasts. Unlike reactive follicles, these neoplastic follicles lack the typical polarization and tangible body macrophages, and they often disrupt the normal nodal architecture. The hallmark genetic event, the T14, 18, Q32, Q21 translocation, juxtaposes the BCL2 gene next to the immunoglobulin heavy chain enhancer, resulting in constitutive overexpression of the anti-apoptotic BCL2 protein. This molecular alteration is pivotal because it confers a survival advantage to the malignant B cells, allowing them to evade programmed cell death and accumulate within the lymph node. Immunohistochemistry plays a central role in distinguishing follicular lymphoma from reactive follicular hyperplasia and other lymphomas. The neoplastic follicles typically express germinal center markers CD10 and BCL6, confirming their origin from germinal center B cells. Importantly, BCL2 expression within these follicles is a key diagnostic clue, as reactive germinal centers usually lack BCL2 staining. This triad of markers, CD10, BCL6, and BCL2, forms the immunophenotypic signature that guides pathologists in confirming the diagnosis. For histotechnologists, ensuring optimal fixation and antigen preservation is paramount, as suboptimal processing can lead to weak or false negative staining, complicating interpretation. From a workflow perspective, specimen triage must prioritize adequate tissue sampling to capture the nodal architecture and allow for ancillary studies such as immunohistochemistry, flow cytometry, and molecular testing. Flow cytometry can detect circulating lymphoma cells in the peripheral blood during the leukemic phase, while molecular and cytogenetic assays confirm the presence of the characteristic translocation. Recognizing the risk of histologic transformation to diffuse large B-cell lymphoma is also critical, as this event dramatically alters prognosis and therapeutic strategy. Transformation is often heralded by architectural effacement, increased proliferation, and loss of follicular markers, underscoring the importance of correlating morphology with immunophenotype. In summary, follicular lymphoma exemplifies how integrated diagnostic approaches, combining histology, immunohistochemistry, molecular genetics, and clinical correlation, are essential for accurate classification and management. For histotechnologists, meticulous attention to tissue handling, fixation, and staining quality directly impacts diagnostic accuracy and patient outcomes. As we transition to mantle cell lymphoma, keep in mind how each lymphoma subtype's unique features demand tailored histotechnological approaches to support precise diagnosis and optimal care. As we delve into mantle cell lymphoma, or MCL, it is essential to appreciate its unique position within the spectrum of mature B-cell neoplasms and the diagnostic challenges it presents, particularly in relation to chronic lymphocytic leukemia or small lymphocytic lymphoma, collectively known as CLL/SLL. Both MCL and CLL/SLL share the expression of CD5, a marker typically associated with T cells but aberrantly expressed on these B-cell malignancies. This overlapping immunophenotype can easily confound diagnosis if one relies solely on limited panels or incomplete clinical information. For histotechnologists, this underscores the importance of comprehensive immunohistochemical panels and meticulous specimen processing to preserve antigenicity, especially when working with lymph node biopsies or bone marrow specimens where these neoplasms commonly manifest. A pivotal distinguishing feature between MCL and CLL lies in the expression of CD23. CLL cells characteristically express CD23, whereas MCL cells are usually negative for this marker. This difference becomes a critical clue during flow cytometric analysis, where the combination of CD5 positivity with CD23 negativity should raise suspicion for MCL rather than CLL. In the histology laboratory, this means that specimen triage must prioritize fresh tissue for flow cytometry to ensure viable cells, as well as formalin-fixed, paraffin-embedded tissue for immunohistochemistry. Proper fixation protocols are vital here. Overfixation or inadequate antigen retrieval can obscure CD23 or cyclin D1 staining, leading to diagnostic pitfalls. The hallmark genetic abnormality defining MCL is the translocation T1114q13q32, which juxtaposes the CCND1 gene encoding cyclin D1 to the immunoglobulin heavy chain locus. This translocation results in the overexpression of cyclin D1, a cell cycle regulator that promotes G1 to S phase progression, driving the neoplastic proliferation characteristic of MCL. Immunohistochemical detection of cyclin D1 is therefore indispensable in differentiating MCL from CLL, as the latter does not express cyclin D1. From a histotechnology perspective, optimizing antigen retrieval methods to unmask cyclin D1 epitopes is critical, as weak or patchy staining can lead to false negatives. Additionally, the interpretation of cyclin D1 staining requires understanding its nuclear localization pattern, which contrasts with cytoplasmic or membranous staining seen in other contexts. In rare instances, MCL may be cyclin D1 negative, complicating the diagnostic landscape. In these cases, SOX11, a transcription factor, serves as an important adjunct marker. SOX11 positivity supports the diagnosis of MCL, even in the absence of cyclin D1 expression, highlighting the necessity of a comprehensive immunohistochemical panel rather than reliance on a single marker. This also emphasizes the role of molecular and cytogenetic testing, such as fluorescence in situ hybridization, FISH, to detect a characteristic translocation when immunophenotypic results are ambiguous. Clinically, MCL tends to follow a more aggressive course than CLL, making accurate diagnosis crucial for guiding prognosis and therapeutic decisions. For histotechnologists, this means that every step, from specimen collection, fixation, decalcification if bone marrow is involved, to staining quality control, directly impacts the pathologist's ability to render a precise diagnosis. Awareness of common pitfalls, such as antigen loss due to poor fixation or misinterpretation of flow cytometry data, is essential to avoid diagnostic errors. In summary, Mantle cell lymphoma exemplifies the complexity of mature B-cell neoplasms, where immunophenotypic overlap with entities like CLL demands a multimodal diagnostic approach integrating histology, immunohistochemistry, flow cytometry, and molecular genetics. Mastery of these diagnostic tools and an understanding of their technical nuances are fundamental for histotechnologists supporting lymphoma diagnoses. With this foundation, we will next explore diffuse large B-cell lymphoma, the most common aggressive non-Hodgkin lymphoma, which presents its own distinct challenges in morphology and laboratory evaluation. Diffuse large B-cell lymphoma, or DLBCL, stands as the most common aggressive subtype of non-Hodgkin lymphoma encountered in clinical practice. Its hallmark is the diffuse proliferation of large neoplastic B cells that efface the normal lymph node architecture, creating a uniform sheet-like pattern rather than the nodular or follicular pattern seen in other lymphomas. Under the microscope, these tumor cells are notably large, with vesicular nuclei that appear open and pale, prominent nucleoli that are easily visible at low magnification, and abundant cytoplasm. These morphological features are critical for initial recognition and are well demonstrated in the photomicrographs accompanying this slide. From a pathology perspective, DLBCL can arise de novo, meaning it originates as an aggressive lymphoma from the outset, or it can develop through histologic transformation from an indolent lymphoma, such as follicular lymphoma. This transformation is clinically significant because it often signals a change in disease behavior and prognosis, necessitating different therapeutic approaches. Therefore, accurate diagnosis and subclassification are essential for guiding patient management. In the histotechnology laboratory, specimen triage is a crucial step to ensure that adequate tissue is allocated for routine histology, immunohistochemistry, IHC, flow cytometry, and molecular studies. Because DLBCL diagnosis relies heavily on ancillary testing, including IHC panels to confirm B-cell lineage and assess prognostic markers, as well as fluorescence in situ hybridization, FISH, to detect gene rearrangements, proper fixation and processing cannot be overstated. Formalin fixation must be carefully controlled to preserve both morphology and antigenicity. Underfixation can result in poor tissue architecture and loss of antigen expression, while overfixation may mask epitopes or degrade nucleic acids, compromising molecular assays. A particularly important diagnostic consideration in DLBCL is the identification of so-called double-hit or triple-hit lymphomas. These variants harbor rearrangements involving the MYC gene in combination with BCL2 and/or BCL6 genes. The presence of these genetic abnormalities confers a more aggressive clinical course and poorer prognosis, often requiring intensified chemotherapy regimens. The schematic on this slide illustrates these rearrangements and underscores their clinical relevance. Detecting these abnormalities depends on high-quality FISH testing, which in turn depends on well-preserved tissue sections prepared by the histotechnology team. Molecular and cytogenetic testing further refine risk stratification and therapeutic decision-making. As histotechnologists, your role extends beyond routine slide preparation to include ensuring that tissue sections are of optimal thickness, free of artifacts, and suitable for multiple downstream assays. Coordination with the clinical laboratory to prioritize testing and manage limited tissue samples is also essential to avoid diagnostic pitfalls. In summary, DLBCL exemplifies the complexity of mature B-cell neoplasms, where morphology, immunophenotyping, and genetic studies converge to establish an accurate diagnosis and guide treatment. Mastery of histotechnology workflow, from specimen receipt through ancillary testing, is vital to support this multidisciplinary diagnostic process. With this foundation, we will next explore marginal zone lymphoma and lymphoplasmacytic lymphoma, entities that often share overlapping features with DLBCL but differ significantly in their clinical behavior and molecular profiles. As we transition into the discussion of marginal zone and lymphoplasmacytic patterns, it is important to appreciate how these entities exemplify the complexity and nuance inherent in diagnosing mature B-cell neoplasms. Marginal zone lymphoma, MZL, and lymphoplasmacytic lymphoma, LPL, are both indolent lymphomas that frequently challenge pathologists and histotechnologists due to their overlapping morphological features and subtle clinical distinctions. Understanding these patterns is crucial not only for accurate diagnosis, but also for guiding appropriate ancillary testing and ensuring optimal patient management. Marginal zone lymphoma itself is a heterogeneous group comprising three main subtypes: extranodal malt lymphoma, splenic marginal zone lymphoma, and nodal marginal zone lymphoma. Each subtype arises in distinct anatomical sites, but shares common histologic characteristics, including a proliferation of small to medium-sized lymphocytes with irregular nuclear contours. A hallmark of MZL is the frequent presence of plasmacytic differentiation, where neoplastic cells exhibit features resembling plasma cells. This plasmacytic component can blur the morphological boundaries between MZL and lymphoplasmacytic lymphoma, making careful histological evaluation essential. Lymphoplasmacytic lymphoma, on the other hand, is defined by a mixture of small lymphocytes and plasma cells, often producing a monoclonal IgM paraprotein detectable in the serum. This paraprotein is the basis for the clinical syndrome known as Waldenstrom macroglobulinemia. Morphologically, LPL can mimic MZL due to the presence of plasmacytoid cells and lymphocytes, but molecular diagnostics have revolutionized our ability to distinguish these entities. The MYD88L265P mutation is highly prevalent in lymphoplasmacytic lymphoma and serves as a critical molecular marker. Its detection through molecular assays provides a powerful tool to differentiate LPL from MZL, which typically lacks this mutation. From a histotechnology perspective, this diagnostic challenge underscores the importance of meticulous specimen triage and processing. Proper fixation is paramount to preserve cellular morphology and antigenicity, especially when immunohistochemistry (IHC) panels are employed to characterize the lymphoid infiltrate. Immunostains targeting B-cell markers, plasma cell markers, and light chain restriction help delineate the cellular composition, while molecular testing for MYD88 mutations requires high-quality nucleic acid preservation. Additionally, flow cytometry can complement morphology by identifying clonal B-cell populations and assessing immunophenotypic profiles, further refining the diagnosis. Common pitfalls include misinterpreting reactive plasmacytosis as neoplastic or overlooking subtle plasmacytic differentiation within MZL. Inadequate fixation or decalcification, particularly in bone marrow biopsies, can compromise staining quality and molecular assay sensitivity, leading to diagnostic uncertainty. Therefore, histotechnologists must adhere to optimized protocols for fixation, decalcification, and embedding, ensuring that tissue architecture and molecular targets remain intact. This integrated diagnostic approach, combining morphology, immunophenotyping, molecular genetics, and clinical correlation, reflects the multi-parameter strategy essential for mature lymphoid neoplasms. By mastering these concepts, you will be better equipped to contribute to accurate lymphoma diagnosis and patient care. Our next discussion will delve deeper into Waldenstrom macroglobulinemia, exploring its pathological features and clinical implications, further illustrating the critical role of histotechnology in hematopathology. As we transition into the topic of Waldenstrom macroglobulinemia, it is important to appreciate how this entity exemplifies the critical role of histotechnology in the diagnosis and management of mature lymphoid neoplasms. Waldenstrom macroglobulinemia, or WM, is a lymphoplasmacytic lymphoma distinguished by the production of a monoclonal IgM paraprotein. This IgM protein is not merely a laboratory finding. It has profound clinical implications that directly influence patient symptoms and treatment strategies. Patients often present with manifestations related to hyperviscosity syndrome, including visual disturbances, headaches, and bleeding tendencies. These symptoms arise because the elevated IgM increases serum viscosity, impairing microcirculation and leading to complications such as retinal hemorrhages or neurologic deficits. Additionally, cryoglobulinemia and peripheral neuropathy may occur due to immune complex deposition and nerve involvement, respectively. From a pathology and histology standpoint, the bone marrow biopsy is the cornerstone specimen for diagnosing WM. Histologically, the marrow shows infiltration by a heterogeneous population of lymphoplasmacytic cells, which includes small lymphocytes and plasma cells. This mixture can pose diagnostic challenges, as the morphology overlaps with other lymphoid neoplasms and plasma cell disorders. Therefore, meticulous specimen triage and processing are essential to preserve cellular detail and antigenicity. Fixation protocols must be optimized to maintain morphology without compromising downstream immunohistochemical staining or molecular assays. Decalcification, when necessary for bone marrow core biopsies, should be carefully controlled to avoid nucleic acid degradation, which would hinder molecular testing. Immunohistochemistry plays a pivotal role in confirming the diagnosis. The neoplastic cells typically express pan-B cell markers, such as CD20, along with markers indicative of plasmacytic differentiation like CD138. Flow cytometry performed on marrow aspirates complements immunohistochemistry by providing quantitative immunophenotypic data, aiding in distinguishing WM from other B-cell lymphomas or plasma cell myeloma. Molecular testing for the MYD88L265P mutation has become a valuable diagnostic adjunct, as this mutation is present in the majority of WM cases. Detection of MYD88 mutation supports the diagnosis and may have therapeutic implications given emerging targeted treatments. Diagnostic reasoning in WM requires integrating clinical findings, serum protein electrophoresis, and immunofixation results demonstrating monoclonal IgM, marrow morphology, immunophenotyping, and molecular data. Common pitfalls include misinterpreting reactive plasmacytosis or confusing WM with marginal zone lymphoma or multiple myeloma, underscoring the importance of a comprehensive, multidisciplinary approach. As histotechnologists, understanding these nuances ensures that specimen handling and staining quality facilitate accurate diagnosis and optimal patient care. With this foundation on Waldenstrom macroglobulinemia, we will next explore cutaneous and peripheral T-cell lymphomas, which present distinct histopathologic features and diagnostic challenges within the spectrum of mature lymphoid neoplasms. This progression will further deepen our understanding of lymphoma biology and the critical role of histotechnology in hematopathology. As we transition into the complex realm of cutaneous and peripheral T-cell lymphomas, it is essential to appreciate how these entities challenge both diagnostic pathology and histotechnology workflows. Cutaneous T-cell lymphomas, particularly mycosis fungoides and Sézary syndrome, represent a unique subset of mature T-cell neoplasms that primarily involve the skin and peripheral blood, respectively. These diseases underscore the critical interplay between morphology, immunophenotyping, and ancillary testing in establishing a definitive diagnosis. From a histopathologic standpoint, mycosis fungoides is characterized by an infiltrate of neoplastic T cells with distinctive cerebriform nuclei that exhibit convoluted, brain-like contours. This nuclear morphology is a hallmark feature that histotechnologists must recognize during microscopic evaluation. In tissue sections, these atypical lymphocytes often localize to the epidermis and superficial dermis, sometimes forming Poirier microabscesses. The fixation process must be carefully controlled to preserve nuclear detail, as overfixation or inadequate fixation can obscure these subtle features, complicating interpretation. Sézary syndrome, the leukemic variant of cutaneous T-cell lymphoma, involves circulating neoplastic T cells with similar cerebriform nuclei. Here, peripheral blood smears and flow cytometry become indispensable tools. Flow cytometric analysis allows for immunophenotypic characterization, typically revealing aberrant loss of pan-T cell markers such as CD7 or CD26, alongside expression of CD4. For histotechnologists, preparing high-quality blood smears and ensuring optimal staining is vital to support these diagnostic modalities. Peripheral T-cell lymphoma, not otherwise specified, PTCLNOS, represents a heterogeneous and often aggressive group of T-cell lymphomas that lack specific defining markers. Morphologically, PTCLNOS can be quite variable, frequently showing pleomorphic medium to large lymphoid cells with irregular nuclei. This variability demands meticulous histologic examination and comprehensive immunohistochemical panels to exclude other T-cell lymphoma subtypes. Immunohistochemistry plays a pivotal role here, requiring robust antigen retrieval techniques and validated antibodies to detect markers such as CD3, CD5, and cytotoxic granule-associated proteins. Misinterpretation can occur if staining is weak or nonspecific, highlighting the importance of stringent quality control in the histology laboratory. Anaplastic large cell lymphoma, ALCL, is another critical peripheral T-cell lymphoma subtype, distinguished by strong expression of CD30 and, in many cases, rearrangements involving the ALK gene. ALK positivity, detected by immunohistochemistry or molecular methods, is more common in younger patients and correlates with a more favorable prognosis. ALCL cells are large and pleomorphic, often exhibiting hallmark horseshoe-shaped nuclei. For histotechnologists, achieving consistent and specific CD30 and ALK staining is essential, as these markers directly influence diagnostic classification and therapeutic decisions. Proper tissue fixation and antigen retrieval protocols must be optimized to preserve these antigens, as suboptimal processing can lead to false negative results. In summary, cutaneous and peripheral T-cell lymphomas exemplify the diagnostic complexity encountered in mature lymphoid neoplasms. Accurate diagnosis hinges on the integration of morphologic assessment, immunophenotyping, flow cytometry, and molecular studies. For histotechnologists, understanding the nuances of specimen triage, fixation, staining quality, and immunohistochemical technique is paramount to support pathologists in rendering precise diagnoses. As we conclude this section, keep in mind that these lymphomas often present diagnostic pitfalls, including overlapping morphologies and antigen expression patterns, which demand a multidisciplinary approach. Our next topic will delve into Hodgkin lymphoma, a classic lymph node-based lymphoma with distinctive histologic and immunophenotypic features. This will further expand our understanding of lymphoid neoplasms and reinforce the critical role of histotechnology in hematopathology diagnostics. As we transition into the critical topic of Hodgkin lymphoma, it is essential to recognize that this disease exemplifies the indispensable role of tissue-based diagnosis in hematopathology and histotechnology. Hodgkin lymphoma, a malignancy primarily involving lymph nodes, cannot be definitively diagnosed through peripheral blood or bone marrow aspirates alone. Instead, it demands a carefully procured tissue biopsy, typically an excisional lymph node specimen, to allow comprehensive histologic evaluation and accurate subtype classification. This requirement aligns closely with our HTL 308 learning goals, emphasizing the importance of specimen triage, fixation protocols, and the preservation of tissue architecture to facilitate precise morphologic and immunophenotypic analyses. Classic Hodgkin lymphoma, or CHL, comprises the majority of cases and is distinguished histologically by the presence of Reed-Sternberg cells. These large, often binucleated or multinucleated cells are embedded within a heterogeneous reactive inflammatory background, which includes a mixture of lymphocytes, eosinophils, plasma cells, and histiocytes. The lymph node architecture in CHL is typically partially effaced, but not completely obliterated, a feature that can be subtle and requires high-quality histologic sections to appreciate. For histotechnologists, this underscores the importance of optimal fixation, usually in neutral buffered formalin, to prevent autolysis and preserve delicate cellular details. Overfixation or underfixation can obscure nuclear features critical for identifying Reed-Sternberg cells, potentially leading to diagnostic pitfalls. In contrast, lymphocyte-predominant Hodgkin lymphoma, LPHL, represents a distinct clinical pathologic entity with unique histologic and immunophenotypic characteristics. LPHL is characterized by large popcorn or lymphocytic and histiocytic L and H cells arranged in a nodular pattern, often with preserved nodal architecture. Immunohistochemistry plays a pivotal role here. LPHL cells express B-cell markers such as CD20 and are negative for CD30 and CD15, which are typically positive in CHL Reed-Sternberg cells. This immunophenotypic distinction is crucial because it influences therapeutic decisions and prognosis. From a histotechnology perspective, performing high-quality immunohistochemical staining with appropriate antigen retrieval and controls is vital to avoid false negatives or nonspecific staining that could mislead the diagnostic interpretation. Beyond morphology and immunohistochemistry, ancillary studies such as flow cytometry and molecular testing may be employed, especially in challenging cases or when differentiating HL from other mature lymphoid neoplasms. However, flow cytometry has limited utility in classic HL due to the scarcity of Reed-Sternberg cells in suspension, emphasizing the primacy of tissue-based evaluation. Molecular and cytogenetic analyses can provide additional insights but are not routinely required for diagnosis. Clinically, patients often present with painless lymphadenopathy in cervical, supraclavicular, or mediastinal regions, sometimes accompanied by systemic B symptoms such as fever, night sweats, and weight loss. These clinical features, combined with histopathologic findings, guide staging, and treatment planning. For histotechnologists, understanding the clinical context reinforces the importance of meticulous specimen handling, from initial receipt and grossing to embedding and sectioning, to ensure that the pathologist has the best possible material for diagnosis. In summary, Hodgkin lymphoma exemplifies the complex interplay between histology, immunophenotyping, and clinical information that defines modern hematopathology. As we proceed, we will delve deeper into the defining Reed-Sternberg cells and their characteristic reactive background in classic Hodgkin lymphoma, highlighting the diagnostic hallmarks that every histotechnologist must recognize and preserve through expert tissue processing and staining techniques. As we transition into the critical topic of Reed-Sternberg cells and their role in classic Hodgkin lymphoma, it is essential to appreciate how this knowledge integrates with your broader learning objectives in HTL 308. Understanding the morphology and immunophenotype of Reed-Sternberg cells is not only foundational for accurate diagnosis, but also exemplifies the complex interplay between histology, pathology, and histotechnology workflows that you will encounter in clinical laboratory practice. Reed-Sternberg cells are the pathognomonic hallmark of classic Hodgkin lymphoma, and their identification is pivotal in differentiating this lymphoma from other mature lymphoid neoplasms. Morphologically, these cells are distinctive. They are large, often binucleated or multinucleated, with prominent eosinophilic nucleoli that create the classic owl's eye appearance. Their abundant eosinophilic cytoplasm further sets them apart within the lymph node architecture. Recognizing these features requires meticulous attention to tissue processing and staining quality. Proper fixation is critical to preserve cellular detail and prevent nuclear or cytoplasmic artifact that could obscure these subtle but diagnostic features. Overfixation or inadequate fixation can compromise morphology, while improper decalcification in bone marrow biopsies may degrade antigenicity, complicating downstream immunohistochemical analysis. The Reed-Sternberg cells do not exist in isolation. They are embedded within a heterogeneous reactive inflammatory background composed of small lymphocytes, eosinophils, plasma cells, histiocytes, and fibroblasts. This reactive milieu reflects the host immune response and is a key diagnostic clue. From a histotechnologist's perspective, maintaining the integrity of this background is just as important as highlighting the neoplastic cells themselves. This requires careful specimen triage to ensure representative sampling of involved lymph node or bone marrow tissue, as well as optimized sectioning techniques to capture the cellular interplay. Immunohistochemistry is indispensable in confirming the diagnosis. Reed-Sternberg cells typically express CD30 and CD15, markers that are robust and reliable for diagnostic confirmation. However, despite their B-cell origin, these cells often show weak or absent expression of classic B-cell markers such as CD20 and PAX5, which can introduce diagnostic pitfalls. This immunophenotypic profile underscores the necessity of employing a comprehensive antibody panel and understanding the nuances of antigen expression patterns. Proper antigen retrieval protocols and validated staining procedures are essential to avoid false negatives or nonspecific staining, which could mislead diagnostic interpretation. In addition to immunohistochemistry, ancillary techniques such as flow cytometry and molecular or cytogenetic testing may be employed to further characterize the lymphoid population and exclude mimics. While flow cytometry has limited sensitivity for Reed-Sternberg cells due to their rarity and fragility, molecular studies can provide supportive evidence for clonality or genetic alterations. In summary, the recognition of Reed-Sternberg cells within their characteristic inflammatory background is a cornerstone of diagnosing classic Hodgkin lymphoma. This requires a coordinated approach involving optimal specimen handling, fixation, staining, and immunophenotypic analysis. As future histotechnologists, your role in ensuring the quality and reliability of these diagnostic steps is vital. Our next discussion will build on this foundation by exploring the subtypes of classic Hodgkin lymphoma and contrasting them with lymphocyte-predominant Hodgkin lymphoma, further refining your diagnostic acumen in mature lymphoid neoplasms. As we delve into the classic Hodgkin lymphoma, HL subtypes, and lymphocyte-predominant Hodgkin lymphoma, LPHL, it is essential to appreciate the nuanced histopathologic and immunophenotypic distinctions that define these entities. This knowledge is foundational not only for diagnostic accuracy, but also for guiding appropriate clinical management. From a histotechnology perspective, the workflow begins with meticulous specimen triage, ensuring that lymph node biopsies are promptly and properly fixed to preserve delicate tissue architecture. Formalin fixation is standard, but attention must be paid to avoid under- or over-fixation, which can obscure subtle morphologic features such as the broad collagen bands characteristic of nodular sclerosis HL or the sparse lymphocytic background seen in lymphocyte-depleted HL. In cases where bone involvement is suspected, decalcification protocols must be carefully selected to maintain antigenicity for downstream immunohistochemical IHC studies. Classic HL is subdivided into 4 principal subtypes: nodular sclerosis, mixed cellularity, lymphocyte-rich, and lymphocyte-depleted. Nodular sclerosis, the most common subtype, particularly in young adults, is defined histologically by broad, sclerotic collagen bands that compartmentalize the lymph node into nodules. Within these nodules, the hallmark lacunar variant Reed-Sternberg RS cells exhibit a distinctive retraction artifact, creating a clear lacuna around the cell. Recognizing this artifact requires well-preserved tissue sections and optimal staining quality, underscoring the histotechnologist's role in producing diagnostically useful slides. Immunophenotypically, classic HLRS cells typically express CD15 and CD30, markers that are critical in differentiating HL from other lymphoid neoplasms. Mixed cellularity HL, often associated with immunosuppression or older age, presents a polymorphous infiltrate rich in eosinophils and plasma cells, with scattered classic RS cells. This subtype's heterogeneity can pose diagnostic challenges, making a comprehensive IHC panel and correlation with clinical data indispensable. The lymphocyte-rich subtype features a predominance of small lymphocytes with relatively few RS cells, while lymphocyte-depleted HL is a rare and aggressive form characterized by scant lymphocytes and numerous RS cells. The latter's aggressive nature necessitates rapid and accurate diagnosis, often supported by ancillary techniques such as flow cytometry and molecular studies to exclude other high-grade lymphomas. In contrast, lymphocyte-predominant HL is a distinct clinical pathologic entity. Its neoplastic cells, known as popcorn or lymphocytic and histiocytic L and H cells, have multilobated nuclei and lack the classic RS cell morphology. Immunophenotypically, these cells are negative for CD15 and CD30, but express B-cell markers like CD20 and epithelial membrane antigen, EMA. This immunoprofile is pivotal for distinguishing LPHL from classic HL, as it carries different prognostic and therapeutic implications. For histotechnologists, ensuring the preservation of antigenicity for CD20 and EMA staining is critical, especially since these markers guide targeted therapies. Throughout this diagnostic process, common pitfalls include misinterpreting fixation artifacts as lacunar spaces, failing to perform an adequate IHC panel, or overlooking the subtle differences in cellular composition among subtypes. Additionally, molecular and cytogenetic testing may provide further diagnostic clarity in ambiguous cases, reinforcing the importance of an integrated diagnostic approach. As we conclude this section on classic Hodgkin subtypes and lymphocyte-predominant HL, remember that your role in specimen handling, fixation, staining, and slide preparation directly impacts the pathologist's ability to render an accurate diagnosis. This, in turn, informs prognosis and treatment strategies, highlighting the critical interface between histotechnology and clinical hematopathology. Next, we will expand our focus to plasma cell disorders, another vital category of mature lymphoid neoplasms, where diagnostic subtleties similarly demand rigorous histologic and immunophenotypic evaluation. As we transition into the topic of plasma cell disorders, it is essential to appreciate these diseases not as isolated entities, but as part of a diagnostic continuum that spans from benign conditions to highly aggressive malignancies. This continuum concept is fundamental for histotechnologists because it directly impacts specimen processing, diagnostic workflows, and ultimately patient management. Understanding the spectrum from monoclonal gammopathy of undetermined significance, MGUS, through smoldering myeloma, overt multiple myeloma, plasmacytoma, and finally plasma cell leukemia, enables us to anticipate the diagnostic challenges and tailor our laboratory approaches accordingly. Plasma cell disorders are defined by the clonal proliferation of plasma cells, which produce monoclonal immunoglobulin proteins detectable in serum or urine. At the benign end, MGUS is characterized by a low-level monoclonal protein and minimal bone marrow plasma cell infiltration, with no evidence of end organ damage. This subtlety makes MGUS a diagnostic challenge, requiring meticulous histological examination and sensitive ancillary testing to avoid overdiagnosis. Smoldering myeloma represents a transitional phase with a higher plasma cell burden, but still lacks the clinical features summarized by the COAB criteria: hypercalcemia, renal insufficiency, anemia, and bone lesions that define active myeloma. Multiple myeloma itself is a malignant plasma cell neoplasm with extensive bone marrow infiltration and systemic manifestations. Histologically, bone marrow biopsies reveal sheets or clusters of atypical plasma cells, often with increased nuclear atypia and mitotic activity. From a histotechnology perspective, the quality of fixation and decalcification of bone marrow core biopsies is paramount. Over-decalcification can destroy antigenic epitopes, compromising immunohistochemical staining for markers such as CD38, CD138, and light-chain immunoglobulins, which are critical for confirming clonality and distinguishing neoplastic plasma cells from reactive populations. Plasmacytomas, localized plasma cell tumors in bone or soft tissue, may precede or coexist with systemic disease. Their diagnosis relies heavily on precise tissue sampling and immunophenotyping. At the aggressive extremelized plasma cell leukemia, a rare leukemic phase marked by circulating plasma cells in peripheral blood and a poor prognosis. This stage demands rapid and comprehensive laboratory evaluation, including flow cytometry to quantify circulating plasma cells and molecular or cytogenetic studies to identify high-risk genetic abnormalities. Specimen triage is a crucial step throughout this continuum. Bone marrow aspirates and biopsies must be allocated judiciously for morphology, immunohistochemistry, flow cytometry, and molecular testing. Each modality provides complementary data that, when integrated with clinical findings, supports accurate diagnosis, risk stratification, and treatment monitoring. Common pitfalls include inadequate fixation, leading to poor staining quality, misinterpretation of reactive versus neoplastic plasma cells, and failure to recognize subtle early disease stages. In summary, plasma cell disorders exemplify the necessity of a multidisciplinary diagnostic approach, combining histology, immunophenotyping, clinical data, and laboratory findings. As histotechnologists, our role in specimen handling, staining quality, and facilitating ancillary studies is vital to this process. The next slide will delve deeper into MGUS, exploring its diagnostic criteria and clinical implications, setting the stage for understanding how early detection and monitoring influence patient outcomes. As we transition into the topic of monoclonal gammopathy of undetermined significance, or MGUS, it is essential to appreciate how this seemingly small clonal plasma cell population carries significant implications for patient surveillance and laboratory diagnosis. MGUS represents a critical intersection of pathology, histology, and clinical laboratory science, where subtle findings in serum protein electrophoresis and bone marrow morphology demand careful interpretation and precise histotechnological techniques. MGUS is characterized by the presence of a monoclonal protein in the serum, detected as a distinct spike on serum protein electrophoresis, paired with less than 10% clonal plasma cells in the bone marrow. Importantly, patients with MGUS lack the CRAB features, hypercalcemia, renal insufficiency, anemia, and bone lesions that define symptomatic plasma cell myeloma. This distinction is crucial because MGUS itself is asymptomatic and does not require immediate treatment, yet it carries a lifelong risk of progression to malignant plasma cell disorders. Therefore, the role of the histotechnologist and the clinical laboratory team is pivotal in establishing an accurate baseline diagnosis and enabling vigilant monitoring. From a histological standpoint, the bone marrow biopsy in MGUS reveals a small, often subtle population of clonal plasma cells that do not disrupt the normal marrow architecture. This subtlety poses a diagnostic challenge. Proper specimen triage is essential to ensure adequate marrow sampling, especially since plasma cells may be patchy or focal. Fixation protocols must preserve cellular morphology and antigenicity to allow for reliable immunohistochemical staining. Decalcification, if required for bone marrow core biopsies, must be carefully controlled to avoid compromising downstream molecular or cytogenetic testing, which can provide additional prognostic information. Immunohistochemistry plays a central role in confirming clonality by demonstrating light chain restriction, either kappa or lambda, within the plasma cell population. This step is critical because reactive plasma cell proliferations can mimic clonal expansions, and misinterpretation can lead to diagnostic errors. The quality of staining, including antigen retrieval and antibody specificity, directly impacts the ability to detect these small clonal populations. Flow cytometry complements immunohistochemistry by providing quantitative and phenotypic data on plasma cells, further refining the diagnosis. Molecular and cytogenetic testing, while not routinely performed in all MGUS cases, can identify genetic abnormalities that may predict progression risk. Understanding these nuances supports diagnostic reasoning and informs clinical decision-making. In summary, MGUS exemplifies how a small clonal plasma cell population requires big surveillance implications. The histotechnologist's expertise in specimen processing, staining quality, and collaboration with pathology and clinical teams ensures accurate diagnosis and appropriate patient management. As we proceed, we will delve deeper into plasma cell myeloma, exploring its pathophysiology and the clinical criteria that distinguish it from MGUS, reinforcing the continuum of plasma cell disorders and the laboratory's role in their diagnosis and monitoring. As we transition into the detailed study of plasma cell myeloma, it is essential to appreciate how this disease exemplifies the intersection of pathology, histology, and advanced laboratory diagnostics, core competencies for any histotechnologist working in hematopathology. Plasma cell myeloma, also known as multiple myeloma, is a malignant clonal proliferation of plasma cells within the bone marrow. These neoplastic plasma cells produce a monoclonal immunoglobulin, often referred to as the M protein, which can be detected in serum or urine. Understanding the pathophysiology of this disease and its clinical manifestations is critical, not only for accurate diagnosis, but also for guiding specimen handling and ancillary testing workflows in the histology laboratory. The hallmark clinical features of plasma cell myeloma are encapsulated by the acronym CRAB, which stands for hypercalcemia, renal failure, anemia, and bone lesions. Each of these manifestations reflects the underlying pathophysiological processes driven by malignant plasma cell expansion. Hypercalcemia arises primarily due to osteolytic bone resorption, where malignant plasma cells stimulate osteoclast activity, leading to bone destruction and calcium release into the bloodstream. This bone destruction is visible on imaging as lytic lesions and is a key diagnostic criterion. Renal failure in myeloma patients often results from the toxic effects of free light chains, small immunoglobulin fragments produced in excess by the malignant cells that deposit in the renal tubules, causing CAS nephropathy. Additionally, hypercalcemia itself can exacerbate renal impairment. Anemia develops as the expanding plasma cell population infiltrates the marrow, crowding out normal hematopoietic elements and reducing erythropoiesis. This marrow replacement also contributes to immunosuppression and increased infection risk. From a histological perspective, plasma cells in myeloma exhibit a spectrum of morphology. Mature plasma cells typically have eccentric nuclei with a characteristic clock-face chromatin pattern and abundant basophilic cytoplasm. However, in aggressive or advanced disease, plasmablasts with larger nuclei, prominent nucleoli, and more open chromatin may predominate, indicating a higher proliferative index and worse prognosis. Recognizing these morphological variations is vital during bone marrow examination and biopsy interpretation. Immunophenotyping plays a pivotal role in confirming the diagnosis and differentiating malignant plasma cells from reactive or benign plasma cell proliferations. Myeloma cells characteristically express high levels of CD38 and CD138, markers of plasma cell differentiation. Aberrant expression of CD56 is common and helps distinguish myeloma cells from normal plasma cells, which typically lack this marker. Importantly, myeloma cells usually lack CD19 and CD45, markers present on normal B cells and hematopoietic precursors, respectively. These immunohistochemical profiles guide the selection of antibody panels and optimize staining protocols in the histology lab. Ensuring proper fixation and antigen preservation is critical here. Overfixation or inadequate decalcification of bone marrow biopsies can compromise antigenicity and lead to false negative or weak staining results. Beyond morphology and immunohistochemistry, diagnosis requires integration of clinical laboratory data, including serum and urine protein electrophoresis, immunofixation, and free light chain assays, which quantify the monoclonal protein burden. Imaging studies such as skeletal surveys or MRI are essential to identify bone lesions, fulfilling the CRAB criteria that define active disease requiring therapy. Molecular and cytogenetic testing, including fluorescence in situ hybridization, FISH, can detect high-risk genetic abnormalities and inform prognosis and treatment strategies. For histotechnologists, understanding the pathophysiology and clinical impact of plasma cell myeloma informs specimen triage decisions, such as prioritizing bone marrow biopsies for rapid processing and selecting appropriate decalcification methods to preserve morphology and antigenicity. Awareness of common pitfalls, like inadequate fixation leading to poor immunostaining or misinterpretation of reactive plasma cells as neoplastic, is crucial for accurate diagnosis. Ultimately, mastery of these concepts enhances diagnostic accuracy and contributes to improved patient outcomes. In the following slide, we will explore peripheral blood findings that may suggest plasma cell myeloma or its leukemic transformation, further expanding our. As we delve into the peripheral blood clues associated with plasma cell myeloma, it is essential to appreciate how subtle morphological features on a peripheral blood smear can provide critical diagnostic insights that complement bone marrow and tissue biopsy findings. For histotechnologists, mastering the preparation and interpretation of peripheral blood smears is a foundational skill that directly impacts the diagnostic workflow for plasma cell disorders and other hematologic malignancies. One of the hallmark peripheral blood findings in multiple myeloma is rouleau formation. This phenomenon occurs when red blood cells stack together in linear arrays, resembling a stack of coins. Rouleau formation results from increased serum protein concentrations, predominantly monoclonal immunoglobulins produced by malignant plasma cells. These abnormal proteins alter the plasma's physicochemical properties, reducing the negative charge on erythrocyte membranes and promoting their aggregation. Under the microscope, this manifests as striking linear stacks of red cells, often accompanied by a diffusely basophilic or blue-tinged background due to the elevated globulin content. Recognizing rouleau is not merely an academic exercise. It serves as a visual clue that should prompt further confirmatory testing, such as serum protein electrophoresis and immunofixation, to characterize the monoclonal protein. Anemia is another common peripheral blood abnormality in myeloma patients, reflecting the complex pathophysiology involving marrow infiltration by neoplastic plasma cells, renal insufficiency affecting erythropoietin production, and chronic inflammation. The anemia may be normocytic and normochromic, but can vary depending on disease stage and comorbidities. From a histotechnology perspective, ensuring optimal smear quality and staining consistency is crucial to accurately assess red cell morphology and detect subtle anisopoicocytosis or polychromasia that may accompany anemia. In more advanced or aggressive disease stages, rare circulating plasma cells may be observed in peripheral blood. These cells are typically absent or extremely scarce in healthy individuals. Their presence indicates marrow spillover or leukemic transformation of the plasma cell clone. When circulating plasma cells exceed a critical threshold, often cited as 2 × 10⁹ per liter, this defines plasma cell leukemia, a rare but highly aggressive variant with distinct clinical implications. Identifying these cells requires meticulous attention to morphological detail and may be supplemented by immunophenotyping through flow cytometry to confirm plasma cell lineage and clonality. For histotechnologists, this underscores the importance of integrating peripheral blood smear findings with ancillary studies, including immunohistochemistry on bone marrow biopsies and molecular or cytogenetic analyses, to establish a comprehensive diagnosis. In summary, the peripheral blood smear remains a vital specimen in the initial evaluation and ongoing monitoring of plasma cell myeloma. High-quality smear preparation, precise staining techniques, and a keen eye for characteristic features such as rouleau formation and circulating plasma cells are indispensable tools in the histotechnologist's repertoire. These findings not only aid in early detection, but also guide subsequent diagnostic testing and therapeutic decision-making. As we conclude our discussion on plasma cell disorders, keep in mind how these peripheral clues integrate with bone marrow morphology and advanced laboratory diagnostics to form a cohesive diagnostic picture. Our next topic will expand into other mature lymphoid neoplasms, further enriching our understanding of hematolymphoid pathology and the critical role of histotechnology in patient care. As we transition into the detailed examination of myeloma bone marrow morphology, it is essential to appreciate how this topic integrates multiple facets of histotechnology, pathology, and clinical laboratory science. Multiple myeloma is a malignant plasma cell disorder characterized by clonal proliferation within the bone marrow, and its diagnosis relies heavily on the careful evaluation of bone marrow specimens. For histotechnologists, understanding the morphological hallmarks of myeloma in marrow biopsies and aspirates is foundational to supporting accurate diagnosis and subsequent patient management. The bone marrow in multiple myeloma typically shows a marked increase in plasma cells, often exceeding 10% of the total cellularity. These plasma cells frequently aggregate into dense sheets or nodular clusters, which can be readily identified on well-prepared bone marrow biopsies. Morphologically, these cells exhibit classic features that are critical for recognition. The nuclei are eccentrically placed, meaning they are pushed to one side of the cell, and the chromatin within the nucleus displays a distinctive clock face or cartwheel pattern. This pattern results from clumped heterochromatin arranged in a radial fashion, a hallmark of mature plasma cells engaged in active immunoglobulin synthesis. Another key feature is the perinuclear HTL, a clear, unstained zone adjacent to the nucleus representing the prominent Golgi apparatus. This structure is essential for the processing and packaging of immunoglobulins, and its visibility depends heavily on optimal fixation and staining protocols. Inadequate fixation or over-decalcification can obscure this feature, potentially complicating morphological assessment. Therefore, histotechnologists must carefully balance decalcification times and reagent concentrations to preserve both cellular morphology and antigenicity, especially since immunohistochemical stains for plasma cell markers, such as CD138 or light chains, are often critical adjuncts in diagnosis. In addition to mature plasma cells, the bone marrow may contain plasmablasts, immature plasma cells with larger nuclei, less condensed chromatin, and prominent nucleoli. The presence of plasmablasts often correlates with a more aggressive disease course and can be a diagnostic clue to higher-grade myeloma variants. Multinucleated or binucleate plasma cells may also be observed, particularly in advanced disease stages. Recognizing these morphological variants is important not only for diagnosis, but also for prognostication and treatment planning. From a workflow perspective, specimen triage is crucial. Bone marrow aspirates provide cytological detail and are often used for flow cytometry and molecular studies, while core biopsies offer architectural context and are preferred for immunohistochemistry and cytogenetic analysis. Proper fixation, typically in neutral buffered formalin, and controlled decalcification protocols preserve tissue integrity and antigenicity, enabling reliable downstream testing. Immunohistochemistry for kappa and lambda light chains helps confirm clonality, while flow cytometry can quantify abnormal plasma cell populations and detect aberrant antigen expression patterns. Molecular and cytogenetic testing further refine diagnosis and risk stratification by identifying chromosomal abnormalities such as translocations involving the immunoglobulin heavy chain locus. In summary, the bone marrow morphology of multiple myeloma is characterized by increased clonal plasma cells with distinctive nuclear and cytoplasmic features, including eccentric nuclei, clock phase chromatin, and a prominent perinuclear HTL. Recognizing plasmablast and multinucleated forms provides additional diagnostic and prognostic information. For histotechnologists, meticulous attention to fixation, decalcification, and staining quality is essential to preserve these subtle morphological details and to facilitate accurate immunophenotypic and molecular analyses. This comprehensive approach ensures that the laboratory provides critical information that guides clinical decision-making in plasma cell neoplasms. As we proceed, we will delve deeper into plasma cell variants and their clinical implications, building on this morphological foundation. As we transition into the detailed exploration of plasma cell variants, It is essential to appreciate how subtle morphological differences can provide profound insights into the biology and diagnosis of plasma cell disorders, particularly multiple myeloma. In histotechnology, recognizing these variants is not merely an academic exercise, but a critical component of the diagnostic workflow that bridges morphology, immunophenotyping, and molecular pathology. Today's focus on flame cells, MOT cells, and other plasma cell variants will deepen your understanding of how these distinctive cytoplasmic features reflect underlying pathophysiological processes and influence laboratory diagnosis. Plasma cells are terminally differentiated B cells, specialize in immunoglobulin production, and their neoplastic counterparts in multiple myeloma often exhibit unique morphological adaptations linked to their secretory activity. Flame cells, for example, are plasma cells characterized by intensely eosinophilic cytoplasm that appears flame-like under routine hematoxylin and eosin staining. This vivid coloration results from the accumulation of immunoglobulins, especially IgA, within the rough endoplasmic reticulum and cytoplasm. Recognizing flame cells is particularly useful because their presence often correlates with IgA myeloma, providing a morphological clue to the immunoglobulin subtype involved. For histotechnologists, achieving optimal fixation and staining quality is paramount to preserving these cytoplasmic details. Overfixation or suboptimal processing can obscure the delicate eosinophilic hue, potentially leading to misinterpretation or missed diagnostic cues. MOT cells represent another fascinating plasma cell variant distinguished by the presence of multiple Russell bodies, large spherical inclusions filled with immunoglobulin that cluster within the cytoplasm, creating a characteristic grape-like or morula appearance. These inclusions signify defective secretion and intracellular retention of immunoglobulin, reflecting a disruption in the secretory pathway. The identification of MOT cells is a hallmark of plasma cell dyscrasias and can be a useful morphological indicator of abnormal immunoglobulin synthesis. From a histotechnological perspective, the visualization of Russell bodies demands meticulous staining and high-resolution microscopy. Inadequate tissue processing or staining artifacts can mask these inclusions, complicating the diagnostic interpretation. Beyond morphology, the recognition of these plasma cell variants informs ancillary testing strategies. Immunohistochemistry panels targeting immunoglobulin light chains and heavy chains can confirm the subtype suggested by flame or MOT cell morphology. Flow cytometry further characterizes the immunophenotype of the plasma cell population, while molecular and cytogenetic analyses provide prognostic and therapeutic insights. Specimen triage is therefore critical, ensuring that adequate fresh tissue or bone marrow aspirate is preserved for these studies complements the morphological assessment and supports comprehensive diagnostic reasoning. In summary, flame cells and MOT cells are more than morphological curiosities. They are integral to understanding the secretory dynamics and pathological state of plasma cells in myeloma and related disorders. For histotechnologists, mastering the nuances of specimen handling, fixation, staining, and imaging is essential to accurately identify these variants and contribute meaningfully to the multidisciplinary diagnostic process. As we proceed, we will examine how immunohistochemistry, flow cytometry, and molecular techniques synergize with morphology to refine diagnosis and guide patient management in plasma cell neoplasms. As we transition into the critical topic of myeloma ancillary testing, it is essential to appreciate how these specialized diagnostic modalities integrate with traditional histopathology to achieve a definitive diagnosis and guide patient management. In the context of multiple myeloma, a plasma cell neoplasm with complex clinical and biological behavior, morphology alone, while foundational, is insufficient to fully characterize the disease. This underscores the importance of a multidisciplinary diagnostic approach that combines histology, immunophenotyping, protein studies, and molecular cytogenetics. For histotechnology professionals, understanding the workflow and technical nuances of these ancillary tests is vital, as specimen handling, fixation, decalcification, and staining quality directly impact the accuracy and reliability of downstream analyses. Starting with immunophenotyping, this technique is indispensable for identifying clonal plasma cells within bone marrow biopsies or aspirates. Flow cytometry and immunohistochemistry are the primary methods employed. Plasma cells in multiple myeloma typically express high levels of CD38 and CD138, markers that confirm plasma cell lineage and differentiation. More importantly, these neoplastic cells exhibit light chain restriction, meaning they express either kappa or lambda light chains exclusively. This monoclonality is a hallmark of malignancy and serves to distinguish neoplastic plasma cells from reactive polyclonal populations that may be present in inflammatory or infectious conditions. From a histotechnology perspective, ensuring optimal antigen preservation during fixation and decalcification is crucial for reliable immunohistochemical staining. Over-decalcification, for example, can mask epitopes and reduce staining intensity, leading to false negatives or ambiguous results. Similarly, flow cytometry requires fresh or properly preserved specimens, and the triage process must prioritize samples for this purpose. Protein electrophoresis, including serum and urine protein electrophoresis, SPEP and UPEP, complements immunophenotyping by detecting monoclonal immunoglobulins, often referred to as M proteins or paraproteins. These proteins represent the secreted products of clonal plasma cells and serve as biomarkers for disease presence and burden. Immunofixation electrophoresis further refines this analysis by identifying the specific heavy and light chain isotypes involved, which is critical for disease classification and therapeutic decision-making. The serum-free light chain assay adds another layer of sensitivity by quantifying free kappa and lambda light chains in the serum, providing valuable information especially in cases of non-secretory myeloma or light chain-only disease. For histotechnologists, understanding the principles behind these assays helps in coordinating specimen collection and transport, as well as interpreting laboratory requisitions and results in the context of tissue findings. Fluorescence in situ hybridization, or FISH, represents the molecular cytogenetic arm of myeloma diagnostics. It detects chromosomal abnormalities such as translocations involving the immunoglobulin heavy chain locus on chromosome 14 or deletions of chromosome 17p, which harbors the TP53 tumor suppressor gene. These genetic alterations carry significant prognostic implications and influence treatment strategies. The success of FISH depends heavily on the quality of the specimen, with fresh or well-preserved bone marrow aspirates preferred. Moreover, histotechnologists must be aware of the potential pitfalls in specimen processing that can degrade nucleic acids or interfere with probe hybridization, such as excessive fixation or inappropriate decalcification protocols. In summary, the diagnosis and characterization of multiple myeloma rely on a multi-parameter approach that integrates morphological assessment with immunophenotyping, protein studies, and molecular cytogenetics. Each modality contributes unique and complementary information, enabling clinicians and pathologists to establish an accurate diagnosis, assess prognosis, and tailor therapy. For histotechnology professionals, mastery of specimen triage, fixation, decalcification, staining, and quality control is essential to support these advanced diagnostic techniques. In the following discussion, we will contrast these findings with reactive plasma cell proliferations, emphasizing the critical role of ancillary testing in differential diagnosis and avoiding common interpretive pitfalls. This comprehensive understanding aligns directly with our HTL 308 learning goals, which emphasize the integration of histology, pathology, and laboratory diagnostics in the evaluation of mature lymphoid neoplasms and plasma cell disorders. As we transition into the critical topic of distinguishing reactive plasmacytosis from plasma cell myeloma, it is essential to appreciate the diagnostic challenges and the pivotal role histotechnology plays in this process. This distinction is not merely academic. It directly impacts patient management, prognosis, and therapeutic decisions. Reactive plasmacytosis represents a benign, polyclonal expansion of plasma cells, typically triggered by infections, autoimmune conditions, or other inflammatory stimuli. In contrast, plasma cell myeloma is a malignant clonal proliferation of plasma cells that often leads to significant morbidity due to bone destruction, anemia, renal impairment, and immunodeficiency. From a pathology and histology standpoint, both conditions involve increased plasma cells within bone marrow or lymphoid tissues, but their cellular characteristics and clinical context differ substantially. Morphologically, reactive plasma cells tend to be heterogeneous and maintain a balanced expression of kappa and lambda light chains, reflecting their polyclonal nature. Myeloma plasma cells, however, are clonal and exhibit light chain restriction, which is a hallmark of neoplasia. This distinction underscores the importance of immunohistochemistry and flow cytometry in the histotechnology workflow. Routine hematoxylin and eosin staining may reveal increased plasma cells, but without adjunctive immunophenotyping, it is impossible to confidently differentiate reactive from neoplastic processes. Specimen triage is crucial here. Bone marrow biopsies or lymph node specimens suspected of plasma cell disorders must be properly fixed and, if necessary, decalcified with protocols that preserve antigenicity for immunohistochemical staining. Over-decalcification can compromise staining quality, leading to false negatives or ambiguous results. Therefore, histotechnologists must balance adequate tissue processing with preservation of cellular detail and antigen integrity. Immunohistochemical panels typically include markers such as CD138 to highlight plasma cells, along with kappa and lambda light chains to assess clonality. Flow cytometry complements this by providing quantitative data on light chain ratios and expression of other plasma cell markers like CD38 and CD56. Molecular and cytogenetic testing further refines diagnosis by identifying chromosomal abnormalities or gene rearrangements characteristic of myeloma, such as translocations involving the immunoglobulin heavy chain locus. Clinically, reactive plasmacytosis lacks the defining Crab features: hypercalcemia, renal insufficiency, anemia, and bone lesions that are often present in myeloma. Laboratory studies in reactive cases show polyclonal immunoglobulin production without a monoclonal spike on serum or urine electrophoresis. In contrast, myeloma patients typically demonstrate a monoclonal protein spike and abnormal serum free light chain ratios, which are critical diagnostic clues. A common pitfall is relying solely on morphology or a single immunohistochemical marker, which can lead to misinterpretation. Reactive plasma cells may appear increased in various inflammatory or infectious conditions, and some myeloma cases may have subtle morphological features. Therefore, an integrated diagnostic approach combining morphology, immunophenotyping, clinical correlation, and laboratory data is essential to avoid misdiagnosis. Understanding these nuances equips histotechnologists to contribute meaningfully to the diagnostic team, ensuring accurate specimen processing, appropriate staining, and reliable interpretation that ultimately guide patient care. This slide's comparative matrix serves as a valuable tool to systematically evaluate and differentiate reactive plasmacytosis from myeloma, setting the foundation for our next discussion on the limitations of single-marker immunohistochemistry and the necessity of comprehensive diagnostic strategies. As we transition into this critical topic, it is essential to emphasize a foundational principle in hematopathology and diagnostic histotechnology. No single immunohistochemical marker can stand alone as the definitive basis for a diagnosis. This concept is not merely academic. It is a practical imperative that directly impacts patient care, laboratory workflow, and diagnostic accuracy. Throughout HTL 308, we have explored the intricate interplay between specimen triage, fixation, decalcification, staining quality, and the application of advanced ancillary techniques such as immunohistochemistry, flow cytometry, and molecular testing. Now we must integrate these elements into a cohesive diagnostic reasoning framework that acknowledges the complexity and heterogeneity of lymphoid neoplasms and plasma cell disorders. In the realm of mature lymphoid neoplasms, Hodgkin lymphoma, and related disorders, immunophenotypic markers like CD5, CD10, CD30, and CD56 are invaluable tools but also potential sources of diagnostic confusion if interpreted in isolation. For example, CD5 expression is classically associated with chronic lymphocytic leukemia/small lymphocytic lymphoma (CLL/SLL) and mantle cell lymphoma (MCL), yet it is also found in certain T-cell neoplasms. Without correlating these findings with lymph node or bone marrow morphology, clinical presentation, and additional markers, a diagnosis based solely on CD5 positivity risks misclassification. Similarly, CD30 is a hallmark marker for classical Hodgkin lymphoma and anaplastic large cell lymphoma, ALCL, but its expression is not exclusive to these entities. Reactive conditions and other malignancies can also express CD30, underscoring the necessity of morphological context in a broader immunohistochemical panel. CD10, often associated with follicular lymphoma and Burkitt lymphoma, illustrates another diagnostic pitfall. While its presence can guide the differential diagnosis, CD10 expression is not pathognomonic and can be aberrantly expressed in other lymphomas or even reactive processes. CD56, frequently positive in multiple myeloma, also appears in other hematologic malignancies, and relying on it alone could lead to erroneous conclusions. This slide's core message is that immunophenotypic markers must be interpreted as part of a multi-parameter diagnostic approach. This approach integrates morphology, immunohistochemistry, flow cytometry, cytogenetics, molecular studies, and clinical data to build a comprehensive diagnostic picture. Such integration is vital to avoid pitfalls that could lead to inappropriate treatment decisions or prognostic errors. As histotechnologists, understanding these nuances informs our role in specimen processing, ensuring optimal fixation and staining quality, and collaborating effectively with pathologists and laboratory colleagues. In the next segment, we will delve deeper into bone marrow biopsy infiltration patterns and examine how special stains complement immunophenotyping to enhance diagnostic precision. This will further illustrate the layered complexity of hematopathology diagnosis and the indispensable role of a multidisciplinary approach. As we transition into the detailed examination of bone marrow biopsy patterns and the application of special stains, it is essential to appreciate how this knowledge integrates with the broader goals of HTL 308. Our focus here is not merely on recognizing histological appearances, but on understanding how these patterns inform diagnostic reasoning, influence laboratory workflow, and ultimately impact patient care in hematopathology. Bone marrow biopsies serve as a cornerstone specimen in the evaluation of mature lymphoid neoplasms, plasma cell disorders, and various lymphomas, including Hodgkin lymphoma. Mastery of their interpretation requires a multidisciplinary approach that combines histology, histotechnology, immunophenotyping, and molecular diagnostics. The histopathological evaluation begins with careful specimen triage. Given the marrow's complex architecture and the frequent presence of fibrosis, proper fixation and decalcification protocols are critical to preserve cellular detail and antigenicity. Over-decalcification can obscure nuclear features and reduce immunohistochemical staining quality, while inadequate fixation may compromise tissue integrity. These technical considerations underscore the histotechnologist's pivotal role in preparing high-quality slides that enable accurate interpretation. When examining bone marrow biopsies, recognizing infiltration patterns is fundamental. Neoplastic involvement often manifests in three principal patterns: interstitial, nodular, and diffuse. Interstitial infiltration is characterized by scattered malignant cells interspersed among normal hematopoietic elements, which can be subtle and easily overlooked without careful scrutiny. Nodular infiltration presents as discrete clusters or aggregates of neoplastic cells, often requiring immunohistochemical confirmation to delineate their boundaries and cellular composition. Diffuse infiltration, by contrast, involves extensive replacement of normal marrow architecture, frequently correlating with advanced disease and poorer prognosis. Special stains play a crucial role in complementing routine hematoxylin and eosin evaluation. Reticulin staining, for example, highlights the fine network of reticulin fibers within the marrow stroma. Increased reticulin fibrosis is a common accompaniment of marrow infiltration by lymphoid neoplasms and plasma cell disorders, such as multiple myeloma. This fibrosis not only alters marrow architecture, but can also cause technical challenges, such as dry taps during aspiration, limiting cytological assessment. Recognizing and grading reticulin fibrosis informs both diagnosis and prognosis, as extensive fibrosis often signals more aggressive disease or marrow remodeling. Immunohistochemistry further refines diagnostic precision by mapping specific cell populations within the marrow. Markers like CD138 are invaluable for identifying plasma cells, while CD20 and CD3 distinguish B- and T lymphocytes, respectively. This immunophenotypic mapping is especially critical when marrow involvement is patchy or when fibrosis limits aspirate yield. It allows pathologists to confirm lineage, assess clonality, and detect minimal residual disease. Moreover, immunohistochemistry guides subsequent molecular and cytogenetic testing by localizing neoplastic cells within the marrow microenvironment. In sum, understanding bone marrow biopsy patterns and the judicious use of special stains are essential competencies for histotechnologists working in hematopathology. These skills ensure that specimens are optimally processed and stained, enabling pathologists to render accurate diagnoses that guide clinical management. As we proceed, we will explore how flow cytometry complements immunohistochemistry, providing a multi-parametric approach to characterizing lymphoid neoplasms and plasma cell disorders. This integrated diagnostic strategy exemplifies the collaborative nature of modern hematopathology and highlights the critical role of histotechnology in delivering high-quality patient care. As we transition into this critical discussion on the complementary strengths of flow cytometry and immunohistochemistry, it is essential to appreciate how these two methodologies integrate within the broader histotechnology workflow and hematopathology diagnostic process. In the context of mature lymphoid neoplasms, Hodgkin lymphoma, plasma cell disorders, and bone marrow pathology, accurate diagnosis hinges not only on recognizing cellular morphology but also on precise immunophenotypic characterization. This slide sets the stage for understanding how flow cytometry and IHC, while distinct in their principles and applications, together provide a more complete diagnostic picture than either could alone. Flow cytometry is a powerful tool that analyzes fresh, viable cells in suspension, allowing rapid, multi-parameter immunophenotyping. This technique excels in detecting subtle aberrancies in antigen expression and assessing clonality, which is invaluable in diagnosing lymphoproliferative disorders and monitoring minimal residual disease. For example, in chronic lymphocytic leukemia or plasma cell myeloma, flow cytometry can sensitively identify abnormal populations that might be missed by morphology alone. However, its reliance on fresh specimens means that specimen triage and timely processing are critical. Poor sample quality or delayed transport can compromise cell viability, leading to inconclusive or false negative results. Moreover, flow cytometry does not preserve tissue architecture, so it cannot provide information about the spatial distribution of neoplastic cells within the lymph node or bone marrow microenvironment. In contrast, immunohistochemistry is performed on fixed, paraffin-embedded tissue sections, preserving the histologic context and allowing visualization of cellular localization and infiltration patterns. This spatial information is indispensable when evaluating the architecture of lymph nodes or bone marrow biopsies, particularly in Hodgkin lymphoma, where the identification of Reed-Sternberg cells within their characteristic inflammatory milieu is diagnostic. IHC panels can be customized to detect lineage-specific markers and differentiation stages, aiding in subclassification of lymphomas and plasma cell disorders. However, IHC is limited by the number of markers that can be assessed simultaneously and requires meticulous optimization of fixation and decalcification protocols to preserve antigenicity and staining quality. Overfixation or harsh decalcification can mask epitopes, leading to weak or false negative staining, which underscores the histotechnologist's role in specimen preparation. By integrating flow cytometry's quantitative immunophenotyping with IHC's morphological context, pathologists achieve a synergistic diagnostic approach. This multi-parameter strategy enhances diagnostic accuracy, informs prognosis, and guides therapeutic decisions, such as selecting targeted therapies or determining the need for further molecular testing. Recognizing the complementary nature of these techniques also informs laboratory workflow decisions, ensuring that specimens are appropriately triaged and processed to maximize diagnostic yield. As we proceed, we will explore molecular and cytogenetic testing modalities, further expanding the diagnostic toolkit and highlighting the indispensable role of histotechnologists in preserving specimen integrity for these advanced analyses. As we transition into the molecular pathology interface, it is crucial to recognize how histotechnologists serve as the vital link between traditional tissue-based diagnostics and cutting-edge molecular analyses in hematopathology. Our work in specimen handling, fixation, decalcification, and slide preparation directly influences the quality and reliability of molecular testing, which has become indispensable for diagnosing and managing mature lymphoid neoplasms, Hodgkin lymphoma, plasma cell disorders, and related hematologic malignancies. Molecular pathology techniques such as fluorescence in situ hybridization, FISH, polymerase chain reaction PCR, and next-generation sequencing, NGS, have revolutionized the diagnostic landscape by enabling detection of chromosomal abnormalities, gene rearrangements, and mutations at a level of precision unattainable by morphology or immunohistochemistry alone. For example, FISH is routinely employed to identify hallmark translocations like T11:14 in mantle cell lymphoma or deletions of 17p in chronic lymphocytic leukemia, alterations that carry significant prognostic and therapeutic implications. PCR and NGS further refine diagnosis by characterizing clonal immunoglobulin gene rearrangements or uncovering mutations in genes such as MYD88 or TP53, which inform risk stratification and targeted treatment decisions. However, the accuracy of these molecular assays hinges on meticulous specimen triage and processing. Histotechnologists must ensure that tissue samples are fixed promptly and adequately to preserve nucleic acid integrity without compromising morphological detail. Overfixation with formalin can cross-link DNA and RNA, reducing assay sensitivity, while underfixation risks autolysis and degradation. Decalcification presents another critical challenge, especially for bone marrow biopsies or lymph node specimens with calcified components. Strong acid decalcifiers can severely damage nucleic acids, rendering molecular testing unreliable. Therefore, gentler agents like EDTA are preferred, despite longer processing times, to maintain DNA and RNA quality for downstream analysis. Slide handling and sectioning also require careful attention. Providing sufficient unstained sections for molecular assays without exhausting the tissue block demands thoughtful coordination with pathologists and molecular laboratories. Histotechnologists must balance the need for adequate material against preserving diagnostic morphology for immunohistochemistry and flow cytometry, which often complement molecular findings. Awareness of these workflow intricacies helps prevent common pitfalls such as sample exhaustion, poor nucleic acid yield, or compromised staining quality. Ultimately, histotechnologists play an indispensable role in bridging morphology and molecular diagnostics. By mastering the technical nuances of specimen processing and understanding the clinical significance of molecular tests, you contribute directly to accurate diagnoses and personalized patient care in hematopathology. This integration of histotechnology with molecular pathology exemplifies the evolving complexity of laboratory medicine and underscores the importance of your expertise in the diagnostic team. In the next section, we will apply these principles to a clinical case study of chronic lymphocytic leukemia, illustrating how molecular findings inform diagnosis and treatment planning. As we begin our detailed exploration of Case 1, we focus on an older adult patient who presents with incidental lymphocytosis, a finding that often prompts a complex diagnostic workup in the clinical laboratory and pathology setting. This case exemplifies the critical integration of morphology, immunophenotyping, and clinical data that is essential for accurate diagnosis of mature lymphoid neoplasms, particularly chronic lymphocytic leukemia, or CLL. Understanding this process is foundational for histotechnology professionals as it directly impacts specimen handling, staining quality, and downstream ancillary testing. In this scenario, the peripheral blood smear serves as the initial diagnostic specimen. The hallmark morphological features of CLL lymphocytes include small, mature-appearing cells with condensed, clumped chromatin and scant cytoplasm. These subtle cytologic details require meticulous smear preparation and optimal staining to preserve cellular morphology. Smudge cells, fragile lymphocytes disrupted during slide preparation, are a common artifact in CLL blood smears. While often considered a nuisance, smudge cells actually provide a valuable diagnostic clue. Employing an albumin smear technique can reduce smudge cell formation, thereby enhancing the quality of the smear and facilitating more accurate morphological assessment. This highlights the histotechnologist's role in specimen triage and preparation, ensuring that slides are of diagnostic quality before they reach the pathologist. Beyond morphology, immunophenotyping by flow cytometry is indispensable in confirming CLL. The characteristic immunophenotype includes CD19 positive B cells, co-expressing CD5 and CD23, with dim expression of CD20. The absence of CD10 and FMC7 negativity further refines the diagnosis, helping to distinguish CLL from other B-cell neoplasms, such as mantle cell lymphoma, which shares CD5 positivity but lacks CD23 expression and is cyclin D1 positive. This immunophenotypic profile guides the pathologist in diagnostic reasoning and informs clinical management. Bone marrow biopsy often reveals involvement exceeding 30% lymphocytes, which is important for staging and prognosis. Here, histotechnologists must carefully process bone marrow specimens, ensuring appropriate fixation and decalcification protocols to preserve cellular detail and antigenicity for immunohistochemistry and molecular studies. High-quality tissue processing is crucial for accurate interpretation of marrow morphology and ancillary testing. This case underscores the multidisciplinary nature of diagnosing mature lymphoid neoplasms. Histotechnologists are integral to the workflow, from preparing pristine peripheral blood smears and bone marrow sections to supporting flow cytometry and molecular testing. Recognizing common pitfalls, such as poor smear quality or antigen degradation during fixation, allows the laboratory team to optimize diagnostic yield. As we proceed, we will contrast this presentation with a case of pancytopenia and splenomegaly, focusing on hairy cell leukemia, which presents unique histological and immunophenotypic challenges. This comparative approach will deepen your understanding of lymphoid neoplasm diversity and the critical role of the histotechnology laboratory in their diagnosis. In this case, we encounter a classic presentation of hairy cell leukemia, or HCL, which is a mature B-cell neoplasm with distinct clinical and pathological features. Understanding this entity is critical for histotechnologists because it exemplifies the interplay between clinical presentation, specimen handling, histologic evaluation, and ancillary testing in the diagnosis of hematolymphoid neoplasms. Patients with HCL typically present with pancytopenia, meaning a reduction across all three major blood cell lines, red cells, white cells, and platelets, and splenomegaly, which is an enlargement of the spleen due to infiltration by neoplastic hairy cells. These clinical signs guide the laboratory's approach to specimen collection and processing. One of the hallmark challenges in diagnosing HCL is the frequent occurrence of a dry tap during bone marrow aspiration. This dry tap results from extensive marrow fibrosis, a reactive process where reticulin fibers proliferate and create a dense, fibrotic environment that physically impedes aspiration of marrow particles. From a histotechnology perspective, this means that the aspirate may be scant or non-diagnostic, necessitating reliance on a bone marrow core biopsy. The core biopsy becomes indispensable for evaluating marrow cellularity, architecture, and the presence of characteristic hairy cells. Proper fixation of the core biopsy is paramount to preserve cellular morphology and antigenicity, which are essential for downstream immunohistochemical and molecular studies. Morphologically, hairy cells are distinctive. They typically have oval or kidney-shaped nuclei with mature, condensed chromatin, and their cytoplasm is pale blue with circumferential, ragged cytoplasmic projections. These hairy projections give the disease its name. Sometimes, the marrow biopsy reveals a fried egg appearance, where the cytoplasm appears clear and abundant around the nucleus. Reticulin staining is a critical step in the histotechnology workflow here, as it highlights the marrow fibrosis that correlates with the dry tap phenomenon. Achieving a high-quality reticulin stain requires meticulous technique, including proper fixation, decalcification if needed, and careful staining to visualize the dense network of reticulin fibers. Immunohistochemistry plays a pivotal role in confirming the diagnosis of HCL. Hairy cells express a characteristic immunophenotype, including positivity for CD11C, CD25, CD103, and annexin A1. These markers help differentiate classic HCL from its variants and other splenic B-cell neoplasms, such as splenic marginal zone lymphoma, which have different clinical courses and treatment implications. Molecular testing, particularly for the BRAF-V600E mutation, is increasingly important, as this mutation is a defining genetic alteration in classic HCL and informs targeted therapy options. From a histotechnology standpoint, ensuring that tissue is well preserved and appropriately triaged is essential to enable these molecular studies. When fresh tissue is available, triaging a portion for flow cytometry is highly beneficial. Flow cytometry complements morphology and immunohistochemistry by providing a rapid, quantitative immunophenotypic profile of the neoplastic cells. However, the dry tap and marrow fibrosis can limit aspirate quality, underscoring the importance of communication between the clinical team, pathologists, and histotechnologists to optimize specimen collection and processing. In summary, this case underscores the critical role of histotechnology in the diagnosis of hairy cell leukemia. From specimen triage and fixation to specialized staining and immunophenotyping, each step must be executed with precision to overcome the diagnostic challenges posed by marrow fibrosis and the dry tap. Mastery of these processes not only facilitates accurate diagnosis, but also guides appropriate clinical management for patients with this indolent but treatable neoplasm. As we move forward, we will examine another hematologic malignancy with distinct clinical and laboratory features, reinforcing the integration of morphology, immunophenotyping, and molecular diagnostics in hematopathology. As we delve into this case, we encounter a classic clinical and laboratory constellation that exemplifies the diagnostic challenges and opportunities in plasma cell neoplasms, particularly multiple myeloma. This malignancy arises from clonal proliferation of plasma cells within the bone marrow, leading to a spectrum of systemic manifestations and distinctive laboratory findings. Understanding the pathophysiology and histopathology of multiple myeloma is crucial for histotechnologists, as it directly impacts specimen processing, staining protocols, and the integration of ancillary studies that guide diagnosis and patient management. Clinically, patients with multiple myeloma often present with symptoms related to the so-called C4 CRAB criteria: hypercalcemia, renal dysfunction, anemia, and bone lesions. In this case, the patient's back pain and renal impairment are red flags that prompt further hematologic evaluation. From a laboratory perspective, one of the hallmark peripheral blood findings is rouleau formation, where red blood cells stack like coins under the microscope. This phenomenon is not merely a curiosity. It reflects the elevated serum levels of monoclonal immunoglobulins secreted by the malignant plasma cells. These proteins neutralize the normal negative charge on erythrocyte membranes, reducing repulsion and promoting aggregation. Recognizing rouleau is a vital clue that should alert the technologist and pathologist to an underlying plasma cell dyscrasia. The cornerstone of diagnosis remains the bone marrow biopsy. Histologically, the marrow is infiltrated by clonal plasma cells exceeding 10% of cellularity, often arranged in sheets or nodular aggregates. Morphologic variants such as flame cells and mott cells may be observed. Flame cells exhibit intensely eosinophilic cytoplasm due to abundant immunoglobulin synthesis, while mott cells contain Russell bodies, intracytoplasmic immunoglobulin inclusions that appear as grape-like clusters. These variants underscore the secretory nature and maturation status of the neoplastic plasma cells and provide important morphologic clues during microscopic evaluation. From a histotechnology workflow standpoint, optimal fixation and decalcification of bone marrow biopsies are paramount to preserve cellular morphology and antigenicity. Over-decalcification can obscure nuclear detail and compromise immunohistochemical staining, while inadequate fixation may lead to poor preservation of plasma cell morphology. Immunohistochemistry panels typically include CD38 and CD138, which are robust plasma cell markers. Demonstration of light chain restriction, either kappa or lambda, confirms clonality and distinguishes neoplastic from reactive plasma cells. Aberrant expression of CD56 is frequently seen in myeloma cells, whereas CD19 is usually negative, aiding in differential diagnosis. These markers are also integral to flow cytometry panels, which complement histologic findings by providing quantitative and phenotypic data on plasma cell populations. Beyond morphology and immunophenotyping, laboratory evaluation incorporates serum and urine protein electrophoresis to detect monoclonal proteins, with immunofixation electrophoresis identifying the specific immunoglobulin isotype. Serum-free light chain assays further refine diagnosis and prognosis by quantifying involved and uninvolved light chains. Cytogenetic studies, particularly fluorescence in situ hybridization, FISH, detect chromosomal abnormalities that influence risk stratification and therapeutic decisions. For histotechnologists, the integration of clinical information with meticulous specimen processing and staining is essential. High-quality bone marrow biopsy sections and peripheral blood smears enable pathologists to accurately assess plasma cell morphology and perform reliable immunohistochemical and molecular studies. Awareness of common pitfalls, such as misinterpreting reactive plasmacytosis or failing to recognize subtle light chain restriction, ensures diagnostic precision. In summary, this case encapsulates the multidisciplinary approach required to diagnose multiple myeloma, highlighting the pivotal role of histotechnology in specimen preparation, staining quality, and ancillary testing. As we move forward, we will explore a lymph node biopsy featuring large, atypical cells, focusing on the differential diagnosis between Hodgkin lymphoma and aggressive non-Hodgkin lymphomas, and emphasizing the critical importance of tissue triage in optimizing diagnostic yield and patient care. As we transition into Case 4, we focus on a lymph node biopsy specimen exhibiting large, atypical cells, a scenario that presents a significant diagnostic challenge in hematopathology and histotechnology. This case is emblematic of the complexities encountered when differentiating among mature lymphoid neoplasms, particularly classical Hodgkin lymphoma, and aggressive non-Hodgkin lymphomas, such as diffuse large B-cell lymphoma or anaplastic large cell lymphoma. Understanding the histologic nuances, immunophenotypic profiles, and molecular characteristics of these entities is essential for accurate diagnosis and appropriate patient management. From a histological standpoint, classical Hodgkin lymphoma is defined by the presence of Reed-Sternberg cells. These are large, often binucleated or multinucleated cells with prominent eosinophilic nucleoli, frequently described as having owl's eye nuclei. Their identification requires careful morphological assessment under the microscope, as these cells are typically sparse within a heterogeneous inflammatory background. This background is composed of reactive lymphocytes, eosinophils, plasma cells, and histiocytes, which collectively contribute to the diagnostic context and aid in subclassification of Hodgkin lymphoma. The preservation or effacement of nodal architecture also provides critical clues. For example, classical Hodgkin lymphoma often shows partial effacement with a mixed inflammatory milieu, whereas aggressive non-Hodgkin lymphomas tend to obliterate normal architecture. In the histotechnology workflow, specimen triage is paramount. Upon receipt, fresh tissue should be promptly allocated for flow cytometry to evaluate immunophenotype and clonality, which are indispensable in distinguishing reactive from neoplastic processes and in subclassifying lymphomas. Concurrently, portions of the tissue must be fixed adequately, usually in neutral buffered formalin, to preserve morphology and antigenicity for immunohistochemical staining. Overfixation or inappropriate decalcification, especially in cases where bone involvement is suspected, can severely compromise antigen preservation and nucleic acid integrity, limiting the utility of downstream molecular and cytogenetic testing. This highlights the critical role of histotechnologists in optimizing fixation times and selecting decalcification protocols that balance tissue softness with preservation of diagnostic markers. Immunohistochemistry is a cornerstone in confirming the diagnosis. Reed-Sternberg cells in classical Hodgkin lymphoma typically express CD30 and CD15, while B-cell markers such as CD20 are often weak or absent. In contrast, diffuse large B-cell lymphoma cells usually express strong CD20 positivity and lack CD15 expression. Anaplastic large cell lymphoma often expresses CD30 and may express ALK protein, which is a useful diagnostic marker. The interpretation of these stains must always be integrated with morphological findings and clinical data to avoid pitfalls such as misclassifying reactive immunoblasts or other large cells as malignant. This case underscores the importance of a multidisciplinary diagnostic approach, where histotechnologists, pathologists, and clinicians collaborate closely. The meticulous processing of tissue, from triage through fixation and staining, directly impacts the quality of diagnostic information obtained. Furthermore, the integration of immunophenotypic, molecular, and cytogenetic data refines diagnostic accuracy and informs prognosis and therapeutic decisions. As we proceed, keep in mind how each step in the histotechnology workflow contributes to the final diagnosis and how attention to detail can prevent common pitfalls such as antigen loss or misinterpretation of reactive changes. In summary, the presence of large atypical cells in a lymph node biopsy demands a comprehensive evaluation strategy. Recognizing Reed-Sternberg cells and their immunophenotypic profile, preserving tissue architecture, and employing appropriate ancillary studies are all critical components. This case exemplifies the intricate interplay between morphology, immunohistochemistry, and molecular diagnostics that defines modern lymphoma pathology and highlights the indispensable role of histotechnologists in facilitating accurate and timely diagnosis. Next, we will explore a comparative matrix of mature lymphoid neoplasms to consolidate these concepts and enhance your diagnostic reasoning skills. As we transition into this comparative matrix of signature findings, it is essential to appreciate how mature lymphoid neoplasms demand a multifaceted diagnostic approach that integrates morphology, immunophenotyping, genetic studies, and specimen-specific clues. For histotechnologists, understanding these hallmark features is not merely academic. It directly informs specimen triage, fixation protocols, staining strategies, and the selection of ancillary testing that ultimately impacts diagnostic accuracy and patient care. This matrix serves as a concise yet comprehensive reference tool, aligning several common mature lymphoid neoplasms against critical diagnostic parameters. By organizing diseases such as chronic lymphocytic leukemia, hairy cell leukemia, multiple myeloma, Hodgkin lymphoma, and mantle cell lymphoma in rows, and diagnostic features, morphology, immunophenotype, genetics, and specimen clues. In columns, the matrix facilitates rapid comparison and highlights the unique constellation of findings that define each entity. Take chronic lymphocytic leukemia, CLL, for example. Morphologically, CLL is characterized by small, mature lymphocytes with condensed, clumped chromatin, often accompanied by smudge cells on peripheral blood smears. These smudge cells are not merely artifacts. They reflect the fragility of the leukemic lymphocytes and can serve as a diagnostic clue during specimen evaluation. Immunophenotypically, CLL cells co-express CD5 and CD23, a pattern that helps distinguish it from other B-cell neoplasms. Cytogenetically, deletion of chromosome 13q is a common abnormality, providing prognostic information. From a histotechnology standpoint, recognizing these features guides the choice of immunohistochemical panels and alerts the technologist to the need for careful slide preparation to preserve delicate cellular morphology. Hairy cell leukemia, HCL, presents a distinct morphological profile with lymphocytes exhibiting characteristic hairy cytoplasmic projections. Immunohistochemistry reveals positivity for markers such as CD11C and annexin A1, while molecular testing for the BRAF 5600E mutation confirms the diagnosis. A critical specimen clue is the frequent occurrence of marrow fibrosis, which often results in a dry tap during bone marrow aspiration. This underscores the importance of proper fixation and decalcification techniques to preserve cellular detail in core biopsies, enabling accurate histologic assessment. In multiple myeloma, the neoplastic plasma cells express CD38 and CD138 and demonstrate light chain restriction, which can be detected by immunohistochemistry or flow cytometry. Clinical features summarized by the CRAB acronym, hypercalcemia, renal insufficiency, anemia, and bone lesions, prompt suspicion and guide specimen selection. Serum protein electrophoresis, HSPIP, and fluorescence in situ hybridization, WISH, provide critical diagnostic and prognostic information, emphasizing the need for coordinated laboratory workflows that integrate morphology with molecular and cytogenetic data. Hodgkin lymphoma is defined by the presence of Reed-Sternberg cells, which express CD30 and CD15 within a heterogeneous inflammatory background. This unique immunophenotype, combined with characteristic morphology, distinguishes it from other lymphoid neoplasms. Meanwhile, mantle cell lymphoma expresses CD5 and cyclin D1, harbors the T11, 14 translocation, and is typically CD23 negative, features that help differentiate it from CLL despite some overlapping markers. For histotechnologists, this matrix is more than a summary. It is a roadmap for specimen handling and diagnostic support. It reinforces the necessity of integrating multiple diagnostic modalities, morphology, immunophenotype, genetics, and specimen context to achieve accurate classification. Understanding these signature findings enables technologists to anticipate ancillary testing needs, optimize staining quality, and recognize potential pitfalls such as fixation artifacts or inadequate decalcification that could obscure critical diagnostic features. As we move forward, we will build upon this foundation by outlining a histotechnology checklist designed to support the complex diagnostic process in hematopathology. This checklist will emphasize best practices in specimen triage, fixation, staining protocols, and quality control measures that ensure the highest diagnostic yield from lymphoid tissue specimens. Mastery of these concepts is essential for any histotechnologist aiming to contribute meaningfully to the multidisciplinary diagnosis of mature lymphoid neoplasms. As we transition into the detailed workflow considerations for mature lymphoid neoplasms, it is essential to appreciate the pivotal role histotechnologists play in ensuring diagnostic precision. Mature lymphoid neoplasms, encompassing entities such as chronic lymphocytic leukemia, CLL, follicular lymphoma, mantle cell lymphoma, and plasma cell disorders, present unique challenges in specimen handling and processing. These challenges arise from the delicate cellular morphology, the necessity for preserving antigenic sites for immunohistochemistry, and the increasing reliance on ancillary techniques like flow cytometry and molecular diagnostics. Our goal in this segment is to equip you with a comprehensive checklist that guides you through each critical step, from specimen receipt to final communication, thereby optimizing the diagnostic yield and supporting accurate pathology interpretation. Upon receiving specimens, the first and most crucial step is verifying specimen adequacy. This involves not only confirming that the correct specimen types have been submitted, such as peripheral blood smears, bone marrow aspirates, core biopsies, or lymph node excisions, but also ensuring that the quantity and quality meet the requirements for downstream testing. For example, peripheral blood and bone marrow aspirate smears require meticulous preparation and staining, often with Reichgemsa, to highlight cellular details such as nuclear chromatin patterns and cytoplasmic granularity. In cases like CLL, where lymphocytes are particularly fragile, the use of albumin smears can stabilize cells and minimize smudge artifacts, which otherwise complicate morphological assessment. Fixation protocols demand particular attention. Core biopsies and lymph node specimens must be fixed in a manner that preserves both morphology and antigenicity. Formalin fixation remains the standard. However, overfixation or improper fixation times can mask epitopes critical for immunohistochemical staining. Bone marrow biopsies often require decalcification, but this step must be carefully controlled. Acid-based decalcifiers can degrade nucleic acids and epitopes, compromising molecular and cytogenetic studies. Therefore, selecting gentle decalcification agents or adjusting exposure times is essential to maintain tissue integrity for these ancillary tests. Tissue triage is a cornerstone of the histotechnology workflow in lymphoid neoplasms. Fresh tissue must be promptly allocated for flow cytometry to evaluate immunophenotypic profiles and clonality, which are indispensable for subclassifying lymphomas. Simultaneously, sufficient tissue should be preserved for immunohistochemistry panels that help distinguish between lymphoma subtypes and plasma cell disorders. Molecular and cytogenetic testing, increasingly important for prognosis and targeted therapies, also require well-preserved nucleic acids and cellular architecture. Effective documentation of specimen handling and clear communication with the pathology and clinical teams ensure that all diagnostic modalities are coordinated seamlessly, preventing delays or loss of critical information. This checklist is not merely a procedural guide. It embodies the integration of histotechnology expertise into the multidisciplinary diagnostic process. By adhering to these steps, you contribute directly to accurate diagnosis, appropriate patient management, and ultimately, improved clinical outcomes. As we proceed, keep in mind that attention to detail at every phase, from specimen receipt through staining quality and communication, forms the foundation of excellence in hematopathology and clinical laboratory practice. As we reach this pivotal point in our module, it is essential to consolidate the complex information we have covered into clear, assessment-ready takeaways that will solidify your understanding and prepare you for practical application in the histotechnology laboratory and beyond. Mature lymphoid neoplasms represent a diverse group of hematologic malignancies with distinct morphologic, immunophenotypic, and genetic characteristics. Mastery of these features is critical not only for accurate diagnosis, but also for guiding appropriate clinical management and prognostication. First and foremost, you should be able to confidently recognize the hallmark morphologic features of the most common mature lymphoid neoplasms. For instance, chronic lymphocytic leukemia, CLL, typically presents with small, mature-appearing lymphocytes, accompanied by characteristic smudge cells on peripheral blood smears. Hairy cell leukemia, HCL, is distinguished by lymphocytes bearing fine, cytoplasmic projections, hairy cells that require careful identification in bone marrow or peripheral blood specimens. Plasma cell disorders, such as multiple myeloma, are identified by the presence of clonal plasma cells exhibiting light chain restriction, which is a critical diagnostic clue. Hodgkin lymphoma, on the other hand, is defined by the presence of Reed-Sternberg cells, large binucleated or multinucleated cells with prominent nucleoli, which are pathognomonic for this disease. Beyond morphology, immunophenotyping is indispensable in refining diagnoses and differentiating between entities that may appear similar under the microscope. For example, CLL cells typically express CD5 and CD23, markers that help distinguish it from other small B-cell lymphomas. HCL cells characteristically express CD11C and annexin A1, markers that are highly specific and aid in confirming the diagnosis. In plasma cell neoplasms, CD38 and CD138 are key markers used to identify plasma cells and assess clonality. Hodgkin lymphoma Reed-Sternberg cells express CD30 and CD15, which are critical for confirming the diagnosis and differentiating it from other lymphomas. In the histotechnology workflow, specimen triage and fixation are foundational steps that directly impact diagnostic accuracy. Proper fixation preserves cellular morphology and antigenicity, which is essential for high-quality immunohistochemistry and molecular testing. Decalcification protocols must be carefully optimized when bone marrow biopsies are involved to avoid compromising nucleic acid integrity, which is vital for downstream molecular and cytogenetic analyses. Flow cytometry complements morphology and immunohistochemistry by providing rapid, quantitative immunophenotypic data, especially useful in peripheral blood and bone marrow specimens. Molecular and cytogenetic testing further refine diagnosis and prognosis by identifying specific genetic abnormalities, such as translocations or mutations, that define certain lymphoid neoplasms. It is equally important to integrate clinical information, laboratory data, and ancillary testing results to arrive at a comprehensive diagnosis. Diagnostic reasoning in mature lymphoid neoplasms requires a multidisciplinary approach, where histotechnologists play a critical role in ensuring specimen quality and accurate test performance. Common pitfalls include inadequate fixation leading to poor staining, misinterpretation of immunohistochemical patterns due to nonspecific staining, and failure to recognize subtle morphologic variants. Awareness of these challenges enhances your ability to contribute meaningfully to the diagnostic process. In summary, the integration of morphology, immunophenotype, and genetic data forms the cornerstone of mature lymphoid neoplasm diagnosis. Your role as histotechnologist is vital in maintaining specimen integrity, performing precise staining protocols, and supporting the pathology team with reliable, high-quality diagnostic material. This comprehensive approach ultimately facilitates accurate classification, informs prognosis, and guides effective patient management. As we transition to the next section, keep in mind how these elements interconnect within the diagnostic workflow, underscoring the collaborative nature of hematopathology and the critical contributions of histotechnology in this complex field. As we conclude this module on mature lymphoid neoplasms, it is essential to emphasize the integrative diagnostic approach that underpins accurate classification and effective patient management. In histopathology and hematopathology, no single element, whether morphology, clinical information, or ancillary testing, can stand alone to provide a definitive diagnosis. Instead, the synthesis of these components forms the cornerstone of diagnostic reasoning, guiding therapeutic decisions and prognostication. Morphology remains the foundational pillar in this process. Careful examination of lymph node or bone marrow architecture, cellular composition, and cytologic details such as nuclear contours, chromatin pattern, and cytoplasmic features offers critical clues. For example, recognizing the characteristic Reed-Sternberg cells in Hodgkin lymphoma or identifying the plasmacytoid differentiation in plasma cell disorders depends on meticulous morphological assessment. However, morphology alone can be ambiguous, especially in cases with overlapping features or subtle infiltrates, underscoring the need for contextual and ancillary data. Clinical context provides the necessary framework to interpret morphological findings. Patient demographics such as age and immune status, presenting symptoms like lymphadenopathy or cytopenias, laboratory abnormalities including peripheral blood counts and serum protein electrophoresis, and imaging studies all help narrow the differential diagnosis. For instance, a young adult with mediastinal lymphadenopathy and B symptoms may raise suspicion for classical Hodgkin lymphoma, whereas an elderly patient with monoclonal gammopathy and bone lesions points toward a plasma cell neoplasm. This clinical information prioritizes the selection of ancillary tests and informs specimen triage. Ancillary studies are indispensable for confirming and refining diagnoses. Immunohistochemistry, IHC panels, enable precise immunophenotyping, distinguishing B-cell from T-cell neoplasms and identifying aberrant antigen expression patterns. Flow cytometry complements IHC by providing rapid, quantitative immunophenotypic data from fresh or viable specimens. Molecular and cytogenetic analyses detect characteristic genetic abnormalities such as translocations involving BCL2 or MYC, which carry diagnostic and prognostic significance. These tests often reveal therapeutic targets, guiding personalized treatment strategies. The role of histotechnology is pivotal throughout this workflow. Optimal specimen triage ensures that adequate tissue is allocated for morphology, IHC, flow cytometry, and molecular studies. Proper fixation preserves cellular morphology and antigenicity, while appropriate decalcification protocols maintain nucleic acid integrity in bone marrow biopsies. High-quality staining, whether routine hematoxylin and eosin or specialized immunostains, facilitates accurate interpretation. Any compromise in these steps can lead to diagnostic pitfalls, such as false negative immunostains or poor DNA quality for molecular testing. Effective communication among histotechnologists, pathologists, and clinicians fosters a collaborative environment that enhances diagnostic precision. As new biomarkers and technologies emerge, continuous education and vigilance are essential to integrate these advances into routine practice. In summary, the diagnosis of mature lymphoid neoplasms exemplifies the necessity of integrating morphology, clinical context, and ancillary evidence. This multidisciplinary synthesis ensures accurate classification, informs prognosis, and guides therapy. Your expertise, as histotechnologists, is critical in maintaining the quality and reliability of specimens that form the basis of this complex diagnostic process. Thank you for your engagement throughout this module and for your vital contributions to patient care in hematopathology.